So happy to have you all here. We also recognize our participants that have joined in online. As you know, this is a hybrid event. We look forward to a very interesting, insightful, and engaging discussion very soon. Thank you. Distinguished ladies and gentlemen, I'd like to welcome you once again and thank you for your patience. Online, we know that participants joined in since 10 a.m. Some of you were here since 10 a.m. and we really appreciate you for your punctuality, especially our speakers, who oftentimes is rare to find most of your speakers really coming on time. They tend to wait to come exactly when they're expected to speak. But really appreciate the courtesy and we're happy to have you here. I'll start first of all by introducing myself. My name is Emeka Ogwano. I work with Nigeria Health Watch and I'll be moderating this event, starting by welcoming you all. It's interesting, the topic we're about to discuss. It's something that virtually everyone can relate with. I have a friend, very close friend, who is also my namesake. He experienced a very peculiar situation when he was expecting. He was about to become a father. And interestingly, to his surprise, he was the one freaking out, and not his wife. On the day she was expecting, she was packing calmly. And he was the one freaking out because he was in Lagos. And you know the whole traffic incidents in Lagos and all of that. And while he was Googling how to manage a pregnancy situation inside traffic, you know, his wife was calmly packing. And he looked at her and asked her, "Why are you so calm?" And she was like, "That it can't be that bad. I mean, what have we not seen with your car? We've seen the worst with your car, so it can't be that bad." It really explains or highlights really the calmness of women in the most difficult situations, especially in a country like ours. We know what our maternal health rates are like in the country. Little over 10,000, little over 1,000, my correction. And we are really here to understand how we can scale innovations to improve our maternal health rates. And we are delighted to invite you to this dialogue, and I'll really hand over to handle the next session, the welcome address, no other than the Managing Director of Nigeria Health Watch, Mrs. Vivian Ihekwazu, to the podium to give the welcome address. Thank you very much.
Thank you very much, Emeka, for that introduction. And as Emeka mentioned, we're really delighted to have all of our speakers here and some of our panelists and some of our delegates who are available online. I'd especially want to recognize some of our very distinguished guests and speakers who are here with us this morning. Dr. Walter Mulumba Kasidi, the WR for WHO, who took it on himself and felt it was important enough to be here in person. So thank you very much, sir, for, of course, being here. And of course, Dr. Salma, our mother, who maternal health is very much in her blood. It goes beyond just a job. I think it's something very personal to her. Dr. Habib Sadauki, the CEO of the head of Sogon, who, of course, is here. And of course, we have Dr. Binyarum Ukaira, who we're very happy to hear, who's the Director of Family Health, and all our other distinguished speakers who are here with us this morning. I think Emeka kind of started off on a very poignant note when he highlighted the calmness of women in some of the most difficult situations. And I know in Nigeria, those situations are exacerbated often by the various issues that compound women's access to quality health care. And of course, for men who often are the companions, the partners of women who are going through childbirth, I think what we need more than ever is champions, men who recognize that access to quality maternal health care should not be a privilege, but is a right. Every woman, irrespective of where she lives, is born, her economic circumstances, should have access to. So this morning, as you can see, and as we have welcomed you to this event, really is focused around scaling up innovations around maternal health. And we know that, maternal health really is a fundamental aspect of public health and really reflects the well-being of current and, of course, future generations. And when you look at a country, we often can say that the degree to which a country devotes to maternal health, how do we safeguard women when they're in childbirth? How do we safeguard them through the continuum of care before they're able to give birth? Can be often seen as a demonstration of how much it values its citizens. And we know that in Nigeria and the wider African continent, that our maternal health statistics are not the best. And even if we look at data, according to WHO, the African continent accounts for 2/3 of maternal health deaths globally. And in Nigeria, this stat is even more alarming. We can say that in Nigeria, we haven't quite hit that point where our stats are going down. And I think there are many economic issues right now that are further exacerbating that. So if we say we have 1,047 deaths per 100 live births, this really highlights the urgent need for us to find those innovative solutions to address some of our really, really poor outcomes for mothers. And according to NDHS, as we often quote, even though 2018 we need to have updated figures, but based on existing data about how women access quality healthcare with skilled healthcare providers, the majority of women still in Nigeria do not give birth with the support of a skilled care provider. And that is a significant gap. So we really need to think, how can we bridge some of these gaps that limit women's ability to give birth in a very safe environment? And our SDG targets of less than 70 deaths per 100 live births, we are far off from achieving that stat. And we look at our neighbors within the African continent, we know that as a country, we are far off from getting anywhere near those figures. And in many events like this one, we keep on talking about those numbers, 1,000, whatever it may be, whichever data point you look at, it's not great. And ultimately, we have to realize that it really does go beyond just the numbers. We look at those numbers, but behind those numbers are people's mothers, sisters. Every single one of us in this room will be touched by this issue, no matter who you are. So it's not just an issue that, I always feel, as a country, we often relegate it to a woman's issue. It's not a woman's issue. This is a population, this is a citizen issue. And that's why for us, we will keep on having these sessions, but we hope we get to a point, I hope in our country, where we see the curve turning and we know that there is hope on the horizon. And how do we leapfrog where we know the gaps exist in our access to, women's access to quality healthcare? And that's why we have this session today. Innovation, if anything, is the way we can address some of these gaps that women face in accessing healthcare. And when we talk about innovation, innovation doesn't always mean creating something new. Innovation is sometimes doing things in a different way. As we say, if we keep on doing things the same way and getting the same results, then that's time to really look at what we're doing. But as I said, there is hope. I think a lot of the speakers today will give us examples of some of these innovations, let's put it that way, that are addressing some of the gaps that women face. So we look at evidence-based solutions such as digital health, telehealth, the motive bundle of care, which you will hear about, that's addressing postpartum hemorrhage. Postpartum hemorrhage is the leading cause of maternal deaths in Nigeria to date. And so these innovations not only address the gaps, but really pave the way for effective maternal health care systems. And some of these innovations are already here. It's just about how do we look at them differently and implement them in different ways. So we hope that with this dialogue and other dialogues that you will have, you will be at, but we don't often just want it to be having these talk shops, those dialogues. We want this event to be beyond just that, but about showcasing some of the solutions beyond just highlighting the problem of how different organizations are using innovation to kind of turn that curve in our maternal health outcomes. And we will look to increase really awareness of some of these successful maternal health care innovations and identify policy recommendations more than anything that can lead to actionable steps for scaling some of these so that beyond just having these small pockets of innovations, so to speak, that address maternal health care, that we're able to scale them so that there's a wider audience, more healthcare facilities, more healthcare providers are using them to address our poor maternal health stats. So really today as an organization, we really invite you to engage in these insightful discussions. I think many of the speakers and panelists will know each other, but it's about exchanging ideas more than anything. And really by amplifying, and for us, we want to create that platform today where we amplify some of these solutions that are addressing some of our poor maternal health outcomes. And we hope to have critical discussions and strategies for scaling some of these up. I think Emotive is one that we keep on highlighting, but it has shown promise, not just in Nigeria, but how do we scale it across the continent in other countries where PPH is one of the causes that leads to maternal deaths. And these things are avoidable. And we always say how we know the solution, but why are we not implementing them? So we hope with this discussion we have today that it will create that opportunity for amplifying these solutions and also giving us hope that, yes, we have an opportunity to really turn the curve and address some of our poor maternal health care outcomes. So thank you again for being here. I can see the room is quickly filling up, and no doubt our guests online will be able to engage throughout the session today. And I invite you all to, yes, find the ways to address our poor maternal health outcomes. So thank you so much for being here. I will hand back over to Emeka, our MC, to take us through to the next session. Thank you.
Thank you very much once again, Vivian. Can we give her a round of applause once again? Crave your indulgence. Yeah. And the next session is a keynote address. But before we welcome Dr. Walter Kzadi Mulombo to give his keynote address, we'd like to recognize the presence of some other speakers who have joined us during the course of the discussion. Professor Hadiza Galadanchi, I'm told she's online. She's the founding director of the African Center of Excellence in Population Health and Policy. We'd also want to recognize the presence of Fatima Muhammad, the consultant nutrition and adolescent health of SFH. You're welcome. We also want to recognize the country director of Farm Access Foundation, from Njide Ndeli. You're very much welcome. Then also, I'd like to welcome Dr. Chukunonso Nwokori, Project Director, Smiles for Mothers at Solina. You're very much welcome. I hope I'm not missed anyone. We also want to welcome Mr. Daniel Momo, the Customer Success Lead at Nivi Inc. We also recognize the presence of the Registrar of the Nursing and Midwifery Council of Nigeria, Mr. Farouk Abubakar. You're very much welcome, sir. And of course, we want to welcome everyone else. Thank you so much for your time. One thing that came out very strongly from Vivian's remark is the fact that we look forward to getting insights into what has worked well, lessons that should be scaled up, but most importantly, we shouldn't look so far, right? It's not really about doing something new. Could be about doing what we've done before, but doing it a bit differently. And that's something that really came out, and as well as raising champions. Champions, we all have champions within us, and not just women. Maternal health is the cornerstone of public health, and it really reflects the well-being of every nation and the future direction of our health indices. But also, before we welcome the WHO country rep, I'm told we have Mentimeter, a little survey to do. Are we ready with that, or we could do that after? Yes, please. Sorry to crave your indulgence. If you could scan, we want to understand what the primary expectations and goals of this session is from you. Yeah, if you could scan the QR code, it won't take much time. Yeah, just want to understand your expectations and ensure that this policy dialogue meets it. While we do that, we also want to recognize the presence of Dr. Charity Chenge, the MNCH lead at the Nigeria Country Office of the Bill and Melinda Gates Foundation. You're very much welcome. Thank you. Okay. So hopefully, and as the key objective, we hope to ensure your expectations are met. And I'm sure we can see most of what has come out. We need to walk the talk. We always like to say this shouldn't be a workshop. This shouldn't be a talk shop, but a workshop, right? Shared understanding, innovation, knowledge, insights, future plans, measures of adoption, making a change, and of course, many other insightful things. So without further ado, we'd like to join me, ladies and gentlemen, in welcoming Dr. Walter Kazadi Mulombo. He's the country director, WHO country director of the World Health Organization, Nigeria. You're very much welcome, sir.
Thank you, MC. Distinguished delegates, friends, colleagues. Let me start by acknowledging the presence of our distinguished guest, Dr. Salma Anas, Special Advisor to the President on Health. I think your presence here says a lot on the importance on this topic. And of course, thank you very much, Vivian, Nigeria Health Watch, and your colleagues for inviting us here, but most importantly for what you do in terms of health advocacy. I think we need that. We need even more of that. And that could be the start of the innovation. Not just Nigeria Health Watch, but many others. So today, I wanted to talk about the WHO, the World Health Assembly resolution to accelerate progress towards reducing maternal, newborn, and child mortality in order to achieve health-related SDGs, particularly SDG 3, which is better health and well-being for all across the life course, especially two targets, 3.1 that address maternal mortality and 3.2 that address newborn and child under 5 mortality. But before I start, I was just looking back and realized that every year in September, member states gather in New York for UNGA. And so was it in 2015 when the SDGs were adopted. And there was a companion strategy, which is the UN Secretary General strategy for women, children, and adolescent health. So I was just looking at the target. It was endorsed by head of state, head of government, expert, and they all commit to certain target by 2030. The strategy was organized around 3 goals. Survive by ending preventable death. And that's why we had these figures that Vivian was mentioning. One of the targets was to make sure that by 2030, maternal mortality ratio is below 70 per 100,000 live births. She was mentioning a figure around 1,000 plus in Nigeria. The target in the remaining 6 years is 70. How we'll do that? Maybe it will be, this session will inform us. There were others. Reduction of child mortality, ending epidemic, HIV, TB, malaria, and neglected tropical diseases. We are kind of on course for HIV in Nigeria. Congratulations. But TB, malaria, neglected tropical diseases, we are very far. And then the reduction of premature death due to non-communicable diseases. Why is it important? Because they all contribute to maternal death. We agreed to end preventable death. The second goal is thrive, ensuring health and well-being for all, and ending all forms of malnutrition, ensuring that all girls and boys have access to good quality early childhood development, substantially reduce pollution, achieve universal health coverage, including financial risk protection and access to quality essential services. Financial risk protection is defined, among others, by out-of-pocket expenditures below, far below 40%. It means household should not be spending more than 40% of the income to seek for health. In Nigeria, it's 71% plus. So we are here to innovate. That's the reality. And the third goal was transform, expand enabling environment, eradicate extreme poverty, ensure that all girls and boys complete primary and secondary education, eliminate harmful practices, discrimination, and violence against women and girls, achieve universal access to safe and affordable drinking water, and to sanitation hygiene. Cholera has become something normal. It shouldn't be, because it's an expression of lack of that access to clean water and sanitation. Enhance scientific research, upgrade technology. This one, at least we are on course, because that's what it's all about today. But why I started with this? These are commitments since 2015, and every year we all congregate in New York to recommit and recommit and recommit. But yet we are where we are today. Very gloom picture as far as maternal mortality is concerned. So now let me go back to World Health Assembly. I just wanted to give that context so we know where we are coming from. I like no more talks. We have to walk the talk. It's very essential. So at the World Health Assembly, 77th session, which was held in May, member states, including Nigeria, endorsed a resolution, again endorsed, after 2015, a new resolution to accelerate progress toward reducing maternal, newborn, and child mortality in order to achieve the 2 targets, 3.1, 3.2. So the resolution 77.5. But we know where we are. Vivian mentioned it. But I'm proud to note that Nigeria was among member states that sponsored this resolution. It invites relevant stakeholders to support, coordinate, and align investment and technical assistance in support of effective implementation of national plan and contribute to acceleration of progress toward reaching this target. I've mentioned the global context, which was re-emphasized by the WHO Director General in his report. He highlighted a few points that I think I should mention here. He said that we are within 6 years remaining to 2030. And many countries are still not on track to reach their SDG targets, particularly those related to reducing maternal mortality and child mortality. I've mentioned those targets before, but I think they will come up again during the discussions. Innovation is not just about new things. Vivian said it. It's also about doing things that work different way. So an examination of key intervention in sexual, reproductive, maternal, newborn, and child health using data from 136 low and middle income countries for the period from 2017 to 2022 indicate, by the way, that in the world, we are far from achieving universal coverage for this intervention that work. They've been proven. With the largest gap involving family planning services, exclusive breastfeeding, and treatment for childhood illnesses. So we know what it works. DG emphasized it. It could be the way we are applying these interventions that are evidence-based. So DG made a few reflections. One of them is the way we use global agreement. And he made a point for investing in and radically reorienting health system intervention to a primary health care approach and addressing health and care workforce shortage, which are key. Primary health care, it's not primary sick care. It's not primary health care center. It's a comprehensive approach with multi-sector policy and action, community engagement and empowerment for them to take responsibility of their own condition and health. And then essential, people-centered health services of good quality, access in a timely fashion, without financial hardship. But also essential public health function for communities to detect outbreak in the communities and initiate early response. That is primary health care. But across the years, primary health care was seen as lower grade health services. It's not. Maybe innovation could also start from there. The problem now in Nigerian context, it was elaborated, it's well known. We know that this part investment. Maternal mortality ratio are still high. Even figures don't match each other. So we have an issue for data. The DHS in 2018 mentioned a figure around 500, half of what the global estimates have for Nigeria. What is the real situation? We need to start there. We need to start to know, to agree from where we are living. So the data quality, data issue is something very essential if we have to demonstrate progress. Nigeria needs rapid acceleration. It's obvious. I don't know how Nigeria will do it. The target is 70 per 100,000 live births. We are at 1,000 at most. Let's take a conservative figure. It's 500, but still a lot of effort that need to happen. So we learn from researchers. What are those innovations that are working? But again, we also need to revisit the 16 key interventions that work and see how they are being implemented. So the resolution, rightly so, launch, echo, and put in place a call to all countries, including Nigeria, to reorient health system toward primary health care approach. I note with appreciation that Nigeria is currently rolling out the Nigeria Health Sector Renewal Investment Initiative and the SWAP approach. Maybe it's something that needs to be looked into. It's a different way of doing things because it addresses a fundamental question, fragmentation of intervention. Fragmentation across different departments, even within the government. Fragmentation encouraged by donors, by us, partners, because we come with our own agenda and we want Nigeria to implement our own agenda. It's very, very important. The call highlights scale up. No more time for pilot studies. It's time to take to scale, large-scale interventions and processes, mechanisms that work, including governance. The report, the WHO also called countries to promote access to affordable, quality, and respectful care. Respectful care that respect the culture. You don't put male to attend to mothers coming to give birth because they will not attend that facility just because you put male there. Their healthcare workforce does not need, you have to put them everywhere. So it has to be culture sensitive. And there are also some key factors like postpartum hemorrhage. That is a key risk factor in terms of maternal mortality. There are also other innovations in that area, and I'm happy to note, for instance, that the Minister of Health and Social Welfare finalized a training manual for managing postpartum hemorrhage and the mechanism, the provision to roll it out. I remember the workshop that took place not long ago in Uyo, the training of trainers, which should lead to a cascading. But we train for a purpose. We very often, we have trained. We have played a part. But training is useless unless it achieves the result. The call to scale up quality integrated child health services for every child and support recovery for lost gain on childhood vaccination and achieving immunization agenda 2020. Nigeria is home to the largest burden of zero-dose children, those who never access a single dose of vaccine. And we are seeing the consequences. Vaccine-preventable diseases becoming common rather than exception. Countries, including Nigeria, were called to invest in establishing network of care with strong referral mechanisms, including supporting services such as functional national referral transportation system, pre-hospital services, laboratories, and blood bank. You will note that this action has been prioritized in the Nigerian context as we speak. Countries were called to facilitate universal access to sexual and reproductive health care services, including for family planning, information and education, integration of reproductive health as contributing factor to maternal, newborn, child, and adolescent survival. The call also emphasized the need for countries to identify and remove barriers that limit access to safe, quality, affordable, sexual, reproductive, maternal, newborn, child, and adolescent health. We know the major delays. The main delays happen at the point of seeking the services and the point of initiating the right treatment. And even after reaching a facility, the care post-partum. These need to be addressed. Country also called upon to invest in country-led effective health information management system, including through enhanced international cooperation in fragile setting to support evidence planning and delivery of services. As a matter of fact, 50% of maternal death globally occur in fragile, conflict-affected, and vulnerable settings. Those settings that are currently experiencing humanitarian crisis, like in the northeast Nigeria and other places. So it's very important that when we plan, to address maternal death, we also remember to prioritize those locations as part of our strategy. I believe is also part of what we see under the health sector renewal investment initiatives. So countries were also called upon to enable access to essential safe quality medicine for pregnant women, for lactating women, mothers, and newborn. A lot of targets, repetitive commitment, endorsement, resolutions, and decision. But still, we are where we are. So I'd like to conclude. I just want to, to trigger discussion. The situation we are seeing is worrisome. It requires different approaches. It requires aggressive approaches. If we want to achieve by 2030 those targets where progress is stalled so far. So the DG report on acceleration toward SDG target for maternal and child health, tabled at WHO 77 in May this year, highlighted the concerning slow progress and stressed the urgent need to accelerate progress to do things differently. Nigeria, like other member states, endorsed that resolution. It's time for action. We are happy, and indeed it's commendable, that Nigeria was not only a co-sponsor of this resolution, but also, in my observation above, there are already visible efforts to implement action in the resolution. No more talk, less talk. Time is for action. WHO is not another organization. It's your organization. It's a member state organization. And Nigeria is part of it. We need to work together to accelerate. It's no longer there and us. It's all of us. So we are committed to that task. We have to implement a truly whole of government and whole of society approach. And I'm happy Nigeria Health Watch, you're already playing your part as part of the society. But I would like to urge all departments of the government to also come on board, because it's not just health. In fact, the other department outside health control 70% of what it will take to address maternal mortality ratio. So I'd like to call on all stakeholders, government, civil society, non-state actors, community themselves, to rally beyond the government leadership in its priority and efforts to truly accelerate progress toward ending preventable maternal mortality and reducing children under the 5 unnecessary deaths. I believe it's doable. It's about commitment, it's about revisiting governance, it's about deliberate action to do things differently. Innovation are coming as an add-on. We have new ideas. We have e-health, telehealth. In some settings, they've proven that it's possible to accelerate. Just by this example of someone driving and browsing how to address maternal mortality ratio, etc., it's an example. It's possible. We just need to stop business as usual and embark in business as unusual. Thank you again for your attention.
Thank you very much, Dr. Walter Mulombo, for calling us to embark. Speaker is someone that has very good experience of addressing not just maternal health outcomes, but health issues in a humanitarian setting and an emergency setting. She's no other than Dr. Salma Hanas, who has been the former Commissioner for Health of Borno State, who had significant experience managing the emergency situation, setting up an emergency desk within the Ministry of Health. We're happy to have someone like you here at the helm of affairs. You're very welcome.
Thank you.
Thank you.
So thank you so much, Mr. MC. Let me start by acknowledging, as in our tradition in Nigeria, though I will do a lot of alignment to existence protocol. Vivian Chikwe Ihekwezu, my friend. Her husband was originally my friend, then before she became my friend. So I now have 2 of them as my friends. The MD of Nigeria Health Watch, WHO country representative, our own dear brother, Dr. Walter Mulombo. We also have here representation from the Federal Ministry of Health, Dr. Binyere Ukai, who is now the Director of Family Health. You're welcome. We have also the Registrar, Midwifery and Nursing Council of Nigeria. It's very important that you are here because you are critical to what we are doing today. We have all our partners from BMGF, Society for Family Health. We have Pathfinder. We have also SOGON represented here. We have the former president of SOGON, who is an expert and a champion in the work we do towards preventing maternal death in Nigeria. Farm Access, my sister is here in Delhi. Smiles for Health, for women, for mothers, and all partners that are here. I recognize all of you. And I now align with the originally laid down protocol. So Mulombo has said a lot in terms of where we are, the situation. And he has also challenged us. but also triggered us to do more. And I said we can do it in Nigeria, and we are committed to do it. But we must do something, as he said, very aggressive. And we are going to accelerate reduction of maternal death. And this is the commitment of His Excellency, President Bola Ahmed Tinubu, who remains committed to ensure that no woman dies as a result of pregnancy or childbirth-related causes. It is a priority. It is a vision of President Bola Ahmed Tinubu for the Renewed Hope Health Agenda. As you are all aware, let me state again that President Bola Ahmed Tinubu is the first time that we had a president that had a well-articulated policy agenda in terms of what he wants to achieve for the health sector in Nigeria, which is around 8 areas. And it comes around and it makes a lot of impact on what we are discussing today on women. First is about the governance issue, the leadership, the coordination. I don't have to mention the problems, we all know them, and WR has mentioned most of them. And then sustainable financing for human resources, for health. We have epileptic financing for health. But even what we've had for health, we've had limited absorptive capacity and also poor utilization. We are all aware of the challenges of release of funds and utilization for the intended purposes. The President is ready to tackle that and increase funding, and we have seen it in 2024. The funding increment, though it might be very little, but it is a step forward. We are also committed to human resources for health, which is a global issue, but of course Nigeria, we've had that problem of human resources for health for several years, and it has worsened in the last few years, in the last maybe I can say 8 years or 10 years. And then with the advent of COVID, it became worse. So this is an area we want to tackle, especially at the primary healthcare level, and also have an integrated healthcare approach. Local production. When we talk about local production, which we have seen President has set the pace with the executive order that was passed recently. Women are the greatest beneficiary of local manufacture of medicines, commodities, and supplies, including assembly of basic equipment and sophisticated equipment in Nigeria. Why do we have high newborn death in Nigeria? It's because of a lot of lack of access to quality services at the point of need, and also for women at the point of need. So local manufacture action is already being rolled out by the Federal Ministry of Health and all its agencies. And the President has done an immediate action by creating an enabling environment to encourage investors in Nigeria and also encourage potential manufacturers to come into the space of health. So several others, he has said the public health emergencies remains a priority, and also data. Without data, we don't know where we are coming from. I was just discussing with one of our media, and because of lack of transparency in information at all levels, especially at the lowest level. So we must have data and also deploy modern technology that will enhance transparency so that we know where we are and then where we have reached at this level and how we want to take it further. So the last is about partnerships. So all these are 8 thematic areas, and I'm happy that we are walking the talk. The Honorable Minister of Health has articulated a 4-point agenda to realize the 8 priorities of Mr. President in those directions. And he has launched the SWAP and the National Renewal Investment for Health, which is currently ongoing. The purpose is to harmonize all resources and maximize effect of resources in Nigeria, and also to be able to get all our partners and support aligned. Not only government development partners, but also government partners to align with the vision and priorities of Mr. President. So having said that, I think I'm supposed to speak on 3 and 1, but I won't go into the situation. It has all been said. So in our agenda, the policy document, which I'm going to share with you, Vivian, of Mr. President, The focus actually is on maternal mortality. That is the major indicator of measurement. And we've had it loud and clear, what Malombo said, we're still 60% to achieve by 2030. So this administration is committed to achieve 35% by 2027. We have 3 years to go. And I believe we're going to perform that magic as much as we can to realize that it's possible to do it, it's realistic. We are also hoping to reduce total fertility rate by 20% in the next few years, and reduce neonatal mortality rate by 40%. You know, a lot of people will say it might be unrealistic, but we strongly feel with acceleration efforts and genuine commitment and transparency, we will be able to realize that. So let me just mention this, that in line with the President's aspiration, which is about national development, we are committed to ensure equity in services. Not only at, of course, services are at subnational level. We have seen the inequity in services, even through the Basic Health Care Fund, which is currently being corrected. And we are engaging with a subnational level to invest more in financial protection and safety net for women and vulnerable children. They are part of the vulnerability group and constitute a greater part of it. And as you said, these discussions is going on in countries that are threatened and in states that are highly threatened by the insecurity, by the humanitarian crisis. And as you said, most of the burden happens, 50% of Nigerian burden occurs in the northeastern part of Nigeria and in the northwestern part of Nigeria. But we have also begun to see a reduction and lack of sustainability and efforts in some states that have been doing well in the southwestern part of Nigeria and also in the southeastern part of Nigeria. So we need a holistic approach to be able, to be able to address all those issues in a comprehensive manner and then within the shortest possible time available to us. So let me say, very important, that we must build on existing efforts. A lot of things have been done in Nigeria in the past that we cannot throw them away. Because one of the key challenges that we also realized was lack of continuity in efforts that have worked and lack of replication and scaling up of those efforts. A lot of investment in the health sector has happened. We are all aware of the journey to realize the Basic Health Care Fund, which started in 2014. It's finally realized that implementation started between 2028 to 2020 with a lot of challenges, but of course it has started. We must continue to step up that, and Mr. President has sustained that effort and also increased budgetary allocation to that effort. We've also seen the investment in family planning, which started in 2012, great efforts. We've sustained that effort since 2012 till today. The last 2 years, we were able to continue and then get approval, presidential approval for continuation of investment in procurement of family planning. This administration has continued. The good news is that it is in our 2024 budget, budgetary allocation by the federal government for procurement of family planning. So there are several things that I will not be able to mention, but things that have worked positively towards improving the health of women. With the MDGs, some of you may recall, the Saving 1 Million Lives are some of impactful projects that have worked. And also recently, the establishment of the RAMCA plus N multi-stakeholder coordination platform. It is also aimed to bring everyone together, to bring all the players on maternal and child health, including adolescent health, together to harmonize resources and maximize impact. And through that, we're able to realize some huge gaps why we are not moving forward in the reduction of maternal death at the subnational level, because the action actually is at the subnational level, where we discovered there are no structures that exist in most states of the Federation. There are no sustained commitments. There are no budgetary allocation for RAMCA issues, including family planning. So with that, we got an approval from the National Council on Health of, 2022, and that every state should go and establish. And that is the only way we can have a sustained commitment for RAMCA. So I'm bringing this on board just to show some of the good efforts we've done in the past. There are so many that requires to be sustained. So going forward, what we have done, and I'm really appreciative of Mr. President for sustaining those efforts and also doing more. And we have seen it in the space of family planning, the BHCF, the executive orders that he has passed on local manufacture of importation of products, and also exploring opportunities and innovations in that direction. Ladies and gentlemen, I also want to say that we've done some good lessons in Nigeria and practices that has worked also in Nigeria in terms of our strategies. The polio eradication is one that has built capacities in the local level, especially at community level. It was what exposed our community and traditional institutions to come into the space of work with the health sector. And this is a good practice that we can also leverage upon. The HIV/AIDS response, of course, is a positive one. And when I talk about it, the weakest link in that space of HIV response is PMTCT. And why is it PMTCT? Is it because it's linked with reproductive health? So that could be the reason, because the woman have to be in the clinic for ANC to be able to know that she's HIV positive or not. She has to come back to deliver at the facility. And those are areas that we're not doing so well. We've responded in terms of doing well to the Ebola, recently to the COVID pandemic, which has helped also strengthen some of our systems, especially tertiary institutions. So there are lots of lessons to leverage upon and do better and bring new innovations. Because as most of us have agreed, WR said it, we must act aggressively. We don't have time to do much. We've designed a lot of policy documents. I think we are good in that, in reproductive health. A lot of you will testify. Just between 2 to 3 years, we've produced a lot of policy documents in Ramka. A lot. And what we do now is I always tell them, just look where there are gaps. You don't need to replicate. You don't need to review the document. What is most important is to implement those policy documents and strategic documents, standard operating procedures, framework at the sub-national level. So those are areas we've done well. So how do we change? What do we do better? I don't have all the answers, but we have made some recommendations on the best way, and we've started doing that within governance space on how do we change the way we do things. So we strongly believe, Mr. President strongly believes a lot needs to be done at the sub-national level. And all of us have seen some of the efforts of Mr. President. Recently, there is a lot of efforts going on to ensure autonomy of the local government. This is where citizens of Nigeria reside. And unfortunately, this is the weakest link in our systems of governance. There is no way a country can develop without having the lowest system where the citizens are, where our desire for universal health care coverage, we said more than 70% of Nigerians should have access to quality healthcare services at the primary healthcare level. Whether you call it the lowest level, but not the low in terms of quality of services. It should have the optimal number of human resources for health to be able to deliver services. So I think this is the direction we are going. You know, devolving power to the local government and also investing in the local government and the subnational level. So recently we've embarked on a lot of advocacy campaigns, specifically on maternal and newborn, where we have one of the worst figures, globally. Engaging with the subnational government. The governors are those that will unlock those potentials. So, and a lot of them, when you engage with them, they also feel it's a responsibility of the federal government. But we all know there are clear demarcations in terms of roles and responsibilities of the federal government and also the state and the local government. But most of them indicate interest and commitment to invest in that. So a lot of discussion we need to shift from implementation at the national level, centralization of efforts at the national level, and devolve to the subnational level, where we engage with the governors. And I tell them they have to identify the problems themselves with our support. Our role is to provide a technical assistance to them. Let them identify the problems. Let them come up with homegrown solutions. And we've engaged with several other governors, and they are in line with the aspirations of Mr. President. especially in acceleration of reduction of maternal death and also newborn and general improvement in child survival. So I truly encourage all our partners that are here today to work in that direction, because that is the only way we can achieve success in doing something differently and in an aggressive manner. And I always say with maternal health, it's so easy to achieve results, because the lifetime of a pregnancy is about 9 months. And if you target every pregnant woman today for quality services, you can see the differences in the next 9 months. When I went to Ondo State, I told the governor before his primary election, because they were the state that used to have one of the best indices in Nigeria on maternal health. Suddenly, it started declining. And from the mixed survey of 2021, we saw they were the worst state. And I told him, you can change it, even within the next few months. Take the services to the communities. Do what you've been doing in the past. Make quality services available. Encourage women to come. They have incentives, because they were giving them incentives even for attending ANC, whether the first ANC visit, second, third, and fourth. And then they will come back again to deliver at those facilities by skilled birth attendants. Retain your workforces, because it also shows so that they have one of the largest migration of workforces, health workforces abroad. So retain them, reverse them, and do something differently. And I'm glad that he's committed to doing that. And so with those kind of engagement at subnational levels and then identifying the problems, I think it's doable. In Sokoto State, what we saw was that the communities, we saw slight increment. There was an increment in family planning uptake from the mixed survey. It used to be less than 3%. It went up to about 8 or so %. But then what happened, there are high maternal deaths in that state. So what's happening, we engage, the governor called all the local government chairmen and all the traditional institutions of the state, and we engage with them. And most of them, simple thing that they said was that they don't have, unlike polio, they had motivation to travel within communities to watch what is happening and encourage people to uptake services. This is not happening in their states. And it also clearly came out that the facilities are not there, the skilled birth attendants are not there, several other things. So if you're working together at the lowest level with the people that matters, it will really bring quick changes that beyond our expectation. And they were ready to scale up a lot of programs that are happening in the state where they identify high-risk women supported by UNFPA and then bringing them to the facility and observe them throughout the period till delivery. And it does not cost money to them. It does not add any additional funding to it. So there is need for us to change our approaches and then look at what has worked. I think in Nigeria we have a large reservoir of what has worked and what has not worked. So there is no need to go and start importation. As he said, there is no need to pilot, but just let's go up and continue to scale up what has worked in Nigeria, what has not worked, and what are the new innovations we are bringing, especially in data management and also in the deployment of new technology to tell us where we are. So I think I will stop here, but before I stop, I just want to say that we remain committed, and I feel Nigerians can do it under the leadership of President Bola Ahmed Tinubu, with the new direction, with the focus on strengthening our subnational level up to the local government level. We can do it. We can change the curve so that it will continue to go up. In fact, not just a curve, we're going to straighten that curve to be a straight, steady increment that will happen. And we are committed, and this is a discussion I've been having. Women's health, maternal death, newborns death, is not a woman's issue. It is an issue for the whole family. It is a community issue. It is a developmental issue. And the president is very committed to ensure that we traject our national development. So it's an integral part, not just of the health sector agenda, but of the overall national development. Thank you so much.
Thank you once again, Dr. Salma Hanas, for that brilliant address. Of course, maternal health is not a woman's issue. In public health, we say, show me your maternal health indices, and I show you where you're headed to as a country. So we really appreciate the political commitment you bring to the table. We are really proud to have someone like you at the helm of affairs. We would like to recognize the presence of the country director of Pathfinder International, Dr. Amina Aminu Doraya, who joined us during the course of the discussions here. Thank you very much. You're welcome. As well as two other speakers who, of course, we have Arit Edem. Apologies if I didn't pronounce that well. You've been here with us from the very beginning. She's the Senior Associate of Help Mom. Thank you for joining us. And of course, we have from Chagozi Abiakam, the Associate Manager of MDoc. You're very welcome. They'll both be speaking on the panel of scaling up maternal health solutions within Nigeria's healthcare system. And we'll be looking forward to that. And without further ado, would want to welcome for a very important address on prioritizing investments that generate innovations to improve maternal health outcomes in Nigeria. No other than Dr. Charity Chenge. She's the Maternal and Child Health Lead at the Bill and Melinda Gates Foundation country office to come and give her address. Thank you very much, Dr. Charity. You're welcome.
The Senior Advisor to the Presidency on Health, Dr. Salma Anas, Director of Family Health, Federal Ministry of Health, Dr. Binyarem Kaire, Country Representative, WHO Nigeria, Dr. Walter Mulabo. Please permit me, distinguished ladies and gentlemen, to stand on the already established protocol this morning. I want to thank and congratulate the MD, Nigeria Health Watch, for putting together this really important event. And we're really pleased to be part of it. Thank you for having us. I bring greetings from the Country Director of the Gates Foundation in Nigeria, Mr. Uche Amao. It's really exciting to be part of this event because the topic, maternal deaths, is one that is really, really important to us and a topic that we really care about, and you'll learn why. The previous speakers have really made my work very easy because they've touched on critical points, and some of the words they've used, you will hear them as I speak because they are resonating for us. Words like innovations, words like accelerate, because to reach the SDG goals between now and then, we cannot move at 10 miles per whatever. We need to accelerate. Words like scale, let's stop pilots, let's scale what we know. Terms like we've done many things that work, let's take it to scale before we start introducing new ones. And I love the way that Dr. Walter helped us to understand innovations. Innovations could be something you've used before or done before, but which you need to do in a different way. That's innovation. It could be the introduction of a new commodity, a new supply that has the potential to avert more deaths. That's innovation. It could be in the approach, and like we will hear from Professor Adiza Galadanchi, we've been treating postpartum hemorrhage in the country for a while. What she will speak to us about and what we will hear about is a change in the approach. Instead of providing sequential services or interventions or administering things in sequence, she will help us understand how administering it together as a bundle is an innovation. She'll also help us understand how introducing the drips, helps us to measure more objectively blood loss in women after delivery. An innovation. It's been there before, but we didn't test it. We didn't know the impact potential. So Professor Adiza will help us to understand from research how using this new innovation can really reduce deaths by up to 60%. And this is why this kind of dialogue is important, because we move from research to enabling policy. So you can see Nigeria Health, which has done a very great job of really organizing the speakers, you know. You have research, you have policy, you have implementation, execution, and because no one can do it alone, we have partnerships, and that's why I'm here. And so at the Gates Foundation, we build partnerships that bring together resources, expertise, and vision from around the globe to identify issues, find answers, and drive change. The problems we try to solve are big, they're complex, they're complicated. For many of the gurus in this room, MNCH is complicated because it's driven by health systems, and the health systems need to work. And so we know we can't have all the answers. We also know that we can make far more progress by working with others. And the story of maternal and newborn health in Nigeria is one where the foundation works through collaborative partnerships to solve a really stubborn problem. And the stubborn problem we're discussing today is the stagnating declines. So results will show that there have been declines, but the pace, and I think we need to emphasize that, the pace of the declines cannot get us to our goals in 2030. And therefore, we need to accelerate. And that's a word that we must all latch onto. It's about accelerating the pace and the movement to get into where we need to be in 2030. And so the contradiction is that while the progress on improving maternal and newborn health outcomes are stagnating, while the progress is stagnating, we actually have interventions that are proven high impact, can avert deaths in millions. But you know, the potential of implementing those high impact interventions are going unrealized. And like previous speakers have said, it could be barriers in the health system, insufficiency of policy frameworks, or we don't have the full enabling environment we have to deliver the high impact interventions. And so because maternal and child mortality declines are stagnating, it's hampering our progress towards achieving the SDG targets. And therefore, scaling up MNCH innovations will accelerate the declines, mortality declines, and drive substantial impacts in Africa south of the Sahara. And so by increasing access to innovations, there's potential to accelerate these inclines. And throughout, my talk, you will hear the word accelerate several times because it's business unusual. So let me tell you something. The pace we are going right now, we are at less than 4%. Think about your speedometer in your car. You could be driving at 60, 100, 200, hopefully not. But the pace we are at now as a country is at 4%, in fact, less than 4%. And we need to amplify this to about 7%. And the innovations we're going to talk about today can get us up to that. We can go as fast as getting to 7% in the declines. And if we're able to do that, we'll accelerate progress towards 2030. And these innovations, taken together, whether they are maternal or newborn innovations, can actually avert up to 1 million maternal and newborn deaths in Africa, across Africa. And 1 million of the 1 million deaths, 260,000 can be averted in Nigeria alone. So we need to move, and we need to move quickly, and we need to scale. Now, one of the innovations we will talk about today, and you will hear from Professor Adiza, is improving the care for PPH using the PPH bundle. We are very pleased, and we're looking forward to her presentation. But there are others. Examples are, the use of multiple micronutrient supplements. Currently, we use iron folate acid in ANC for women, but there is potential in using MMS, multiple micronutrient supplements, because it's able to avert deaths that are linked to adverse outcomes from, micronutrient deficiencies. And so that's an innovation. The ability to switch from just iron folate acid to MMS is an innovation. Another innovation will be routine administration of maternal azithromycin, which could address sepsis, maternal sepsis, which again is a leading cause of death for women in Nigeria. Also, we have the newborn bundle, and of course the handheld ultrasound scans, which can be used at primary healthcare level. Now, taken together, these innovations I've called, whether it's the PPH bundle, the MMS, the even intravenous iron, azithromycin given routinely, if you think about it, they can address some of the biggest drivers of deaths, drivers like hemorrhage, sepsis, anemia. So indeed, if we're able to accelerate and expand the adoption of these innovations, we will be moving very quickly towards achieving our goals for SDGs. And so I think the previous speakers have spoken about availability, accessibility. All these have to do with also barriers in health systems, right? So it's not enough for us as partners to only address providing the innovations or researching the innovations. Part of our investments also help to unlock the barriers that we experience in the health system. Also, part of our interventions provide partnerships to provide enabling or policy frameworks for these innovations. For example, no matter how many innovations you have, whether it's a product or service, a commodity, if you don't have the policy from the Ministry of Health to introduce those innovations, who's going to guide? If you don't have clinical protocols, if you don't have training guidelines, Walter was speaking about the training that happened in New York, I think 2 weeks ago. These are part of the enabling frameworks or policies or guidelines that we require to deliver innovations. And so it's not enough to just, and these are part of what could become a bottleneck in a health system. If healthcare workers are not applying or administering an innovation in a standardized way, it's a bottleneck. And it also affects the quality of delivery of the innovations. So these are the kind of partnerships that we're also going to ensure that we have expanded adoption of innovation. And therefore, our goal as the Gates Foundation, and in partnership with diverse stakeholders in Nigeria, is to catalyze, again, that's a synonym for accelerate, right? Is to catalyze the expanded adoption of proven life-saving MNCH innovations that address the leading causes of maternal and newborn deaths via supporting the delivery of these packages, collecting data, and gathering information. We've all mentioned the data around MMR. Depending on which report you pick is different. And so generating data to help us understand where exactly we are is also important. I previously mentioned supporting health systems, enablers to unlock barriers in delivery of services. We also recognize that improving quality of care can stimulate demand. If women know that they will get high quality services, the waiting times will not be as long, they will get commodities in the facilities, the commodities are not counterfeit, they are high quality products for the right price, it will increase demand and there'll be sustained uptake of the innovations. So it's one thing to deliver innovations, another thing also for it to be for there to be demand for it. And so since late last year, our team has engaged with the Coordinating Minister of Health and Social Welfare, his team, and other key stakeholders to discuss a suite of MNCH innovations for crashing maternal and newborn mortality. We also shared the research done in country, e.g. the emotive research, which Professor Hadiza will speak to, which demonstrated the efficacy and the potential pathways to scale innovations. Our efforts have led to the prioritization of 4 innovations in particular that we're throwing our weight behind and really creating investments around. They include, the MMS I mentioned, multiple micronutrient supplements, postpartum hemorrhage bundles, maternal azithromycin, and the newborn bundles. And our engagement is in the hope that these innovations will be included in the package of services to be funded and scaled under the sector-wide approach. And so to drive the introduction, adoption, and scale of these life-saving innovations, our focus over the next months will also be to deepen our ongoing engagement and suite of partnerships to support procurement of these defined bundles, also to expand midwifery services to deliver the packages. And we are partnering with MPHCDA on redesigning midwifery-led models of care to deliver quality maternal and newborn health services and MNH innovations at the PHC level. This will support the government's aspiration to deploy thousands of midwives across targeted BHCPF facilities. Some of our partnerships and investments in supply chain are also to improve the quality. Many of us in the room know the story around oxytocin. Oxytocin is not a new commodity. We've been using it for years in this country. However, the quality of the product has been questioned. And so part of our investments will improve quality and on-shelf availability of commodities that are already established, aside from then supporting government to increase the introduction and adoption of new innovations. Some of our investments too will provide comprehensive distribution and support services in partnerships with manufacturers and local distributors. Like the SA mentioned, we want to be able to deepen our partnerships and encourage, stimulate local production. So some of our partnerships are doing this. We also want to provide partnerships that support policy enablement, offer policy framework. We can't provide policy framework. What our mandate? That's the mandate of the Federal Ministry of Health. So our partnerships with the Federal Ministry of Health will ensure that there are policy frameworks to guide the introduction of these innovations. So I want to end by saying that we are really excited about these partnerships. Many of them are already underway. Some are being, created as we speak. And they are with governments, with non-government players, but we're working closely with all stakeholders under the leadership of the coordinating minister and within the Health Sector Renewal Initiative and, of course, the SWAP. And ultimately, we will crash maternal and newborn mortality in Nigeria. Thank you.
Thank you so much once again, Dr. Chenge, for that beautiful remark. If there's one thing we know about the Gates Foundation is that they put their money where their mouth is. And so it's unfortunate that some of our speakers are not here. We would have loved to take questions at this point. But then again, okay. So I've been motioned to move ahead. Perhaps we'll do that during the panel sessions then. Right about now, we are expected to take a presentation. Wondering if we have this queued. Online. Yes. Okay, I'm aware that Professor Hadiza Gadalanchi is online. So if we can get her presentation on so that she
another
You have So if we could have a very quick 15 minutes tea break, then we'll come back and start the first panel. Would have loved to take questions now, but due to time, we'll take them after the first panel conversation that would also be focused on Professor Hadiza's presentation. Thank you so much once again for your time and attention. We would join back in 15 minutes. Of course, if you don't finish, you can bring it back here and we'll convert it to a walking tea break. Thank you.
Flying so high, da, 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 da.
emotive approach has gained significant recognition, commendation. It has been widely accepted, and would have the director of programs at Nigeria Health Watch, no other than Dr. Kemisola Abaoye, to take us through this panel, to moderate this panel, to have a deep dive into the emotive approach, into improving care for postpartum hemorrhage within Nigeria's health system. Interestingly, we would like to recognize someone very important here. He was here almost all morning, and he's no longer here. No other than Professor Lufade from the Rotary Foundation, who actually had some interesting insights into what they are doing to address MPCDSR, which is also, he would have very, very key questions here and comments for this session. So he's actually looking forward. Dr. Kemi Aboye would like to welcome you to the stage. I'm so sorry. Please, apologies for pronouncing that name that way, yeah. So she's going to welcome the key speakers, the panel speakers for this session. Thank you, Kemi. You have the floor, please.
Thank you so much, Emeka, and apologies not accepted for ruining my name. You're my colleague. Learn it. Okay, that's just a joke. All right, good afternoon. It's already afternoon. Good afternoon, everyone. Thank you so much for being here and for being so patient. And a lot has been said already about why we're here and what our maternal health rates are, and how important scaling up innovations is to, I'm trying to use the right words, accelerate progress and crash our maternal mortality rate. So without further ado, allow me to welcome my esteemed panelists, Dr. Binyerem Ukaire, who is the Director of Family Health at the Federal Ministry of Health. You're welcome, Ma. If you could please take that seat. The one tilted is for the moderator so I can see your amazing faces. Fatima B. Mohammed, who is Consultant Nutrition at ANRIN, Accelerating Results Program, and she is the adolescent and also the head of the Adolescent Health Project at Society for Family Health. You're welcome, Ma. Dr. Habib Sadauki, immediate past president of the Society of Gynecology and Obstetrics, Gynecology and Obstetrics of Nigeria, SOGON. Please welcome. Dr. Chukwunonso Waokore. Okay, now I know how Emeka felt. Okay, apology accepted. Project Director of Smiles for Mothers at Solina Center for International Development and Research, CIDA. Thank you so much. Okay, so to take us on in the discussions, we've already heard the amazing presentation by Prof. Galadanchi. This panel focuses specifically on scaling up the emotive trial, but emotive bundle of care. But beyond that, it also looks at how PPH management can be improved in Nigeria. And we heard from the representative of government, we heard from Dr. Salma, the Special Advisor to the President on Health, about the fact that there is political will for this, that the president, the highest official in Nigeria, is keenly invested in improving maternal health outcomes. We've also heard from Prof. Galadanchi how the emotive bundle is influencing policy. Well, I wanted you, Dr. Binyerem, to share specifically how the Federal Ministry of Health is scaling up the approach, the emotive bundle, specifically in your already existing programs and policies. Prof. Galadanchi mentioned that the bundle of care has been adopted into a policy for management of PPH. Could you share specifically what's been done and what other considerations you're having for scale-up and diffusion?
Thank you very much for this opportunity. I want to start by thanking the Nigerian Health Watch for giving us this opportunity, and also I bring you greetings from the Coordinating Minister of Health and Social Welfare, Professor Muhammad Alupati, who has, in his wisdom, adapted the Mr. President's renewed hope agenda by coming up with the Nigerian Health Sector Renewal Investment Initiative. And so I think the preamble, the background has already been laid. In my department, which is the Department of Family Health, we have the program that is domiciled there, known as Reproductive, Maternal, Newborn, Child Health, Adolescent, Elderly Health program, domiciled in the department. And so you can agree with me that maternal and newborn health is right under the department. And that is why, following the evidence-based intervention that emotive, which Professor Hadiza has presented, we have moved very fast, along with all our stakeholders, because everything we do, we realize that we have to do our work with our stakeholders, and even at the multisectoral level, knowing that reduction of maternal and newborn health is a multisectoral issue, and all that social determinants of health that have to come into play from other sectors are very critical and have to be carried along. So moving the research finding into policy, and from policy, of course, to implementation, to evaluation, and all that, and then having our maternal mortality indices improved. We have quickly integrated the emotive bundle into our safe motherhood strategy document. And also to take it further and give granular information, we have also developed a guideline for health workers to make use of in managing postpartum hemorrhage, and we have prioritized the emotive bundle. However, I also want to add that just as it is very prime or very uppermost in the program of the coordinating minister to crash maternal mortality and under 5 mortality, and particularly the newborn, we think that the 3 main causes, because we think that addressing the 3 main causes, there are many causes as has been shown, but the 3 main causes of maternal mortality, of which PPH is the highest, should be addressed, followed by preeclampsia, eclampsia, as well as maternal sepsis. And so the department is rolling out these documents, and we just started. And we started with the guidelines for postpartum management care. And the next thing is that this document is going to be finalized and printed and disseminated to all the subnational levels for use. And we anticipate a situation where all implementers in Nigeria, both government partners, everybody will come together to implement one national, a common national priority. And that's all about the concept behind the swap approach. So that together we come together, bring our resources together, and make sure that we implement national priorities. And in this case, for our focus today, reduction of maternal mortality and neonatal mortality. Several other things we are doing are all integrated there. I would like to approach this, will I say, from health system strengthening approach. Once there's an evidence-based intervention, just like now we have the emotive, we follow the health system strengthening approach, because if you don't strengthen the health system, how can we have sustainability? And so we ensure that when we have integrated this into policy and ensured we've provided strategic direction, we also want to look at the leadership and governance at all levels in terms of coordination of effective implementations. We want to look at the health services delivery. There has to be equitable, quality, integrated RAMCAN, or in this case, maternal newborn health service delivery. We have to ensure that we have skilled workforce for maternal and newborn health. We have to ensure that we integrate the emotive data into the existing National Health Management Information System. We have to ensure efficient funding, that we bring both our domestic funding together with the ODAs, the Overseas Development Assistance together, and ensure that we were able to move our indicators of maternal mortality at least close to the SDG of less than 70 maternal deaths per 100,000 live births. And one other thing that's very critical is community engagement through health promotion. There's a lot that has to be pushed out there to ensure social behavioral change, even among healthcare workers, to be sure that they implement the emotive. And also, these are emergency drugs. Apart from massage, which is not a drug, the Zito-6, the misoprostol, the tranexamic acid, the IV fluid, they are emergency drugs. And there must be a trade. They must be always there. So we have to ensure adequate supply chain logistics, that these drugs are available in all health facilities where there are mothers delivering. And this cannot be done by the national alone. Together with the subnational level, it's already been said here over and over that implementation is where the action is right now. We have to ensure that the primary care level to all women, pregnant women, is ensured, be it at primary level, secondary, tertiary. Women are delivering in all these places and even in the community. But particularly, we also have to make our PHCs, primary healthcare centers, as against primary healthcare, very, very functional and efficient in delivering quality health services. And we are going to ensure that the emotive bundle is also prioritized and is part of the interventions, along with all the ones mentioned by Dr. Cheng of Bill and Melinda Gates, in the RAMCAN swap priority plan that is currently being developed and will soon be finalized. So there are so much. Maybe I should just stop here. Thank you.
Thank you so much. Thank you for that response. Indeed, you need a whole of systems approach to implementing innovations, and that's how it will be sustainable. But before you drop the mic, could you please speak to how the Federal Ministry of Health is tracking implementation of? So I understand that the emotive bundle will be implemented in an integrated manner with your existing policies, but you know that with the accelerated action for impact initiative, data is key. So what are your thoughts on how you are going to track, or how you are tracking implementation of the emotive bundle and uptake and adoption, and how it's changing things?
Okay, first and foremost, after we've developed our policy documents, we want to ensure we give technical support or assistance to the states. They have to, own up with the documents and be able to implement it accordingly with all the directions, steps already laid out for them in that document. And of which one of them, of course, is data management for the emotive intervention. And this cannot exist alone. We have to integrate it into the existing data management system for maternal and newborn health. And so it's still work in progress. And so we are going to ensure that start working together and collaborating with the Department of Planning, Research and Statistics, who has the purview for the monitoring and evaluation of health data in the country, that we ensure that this is integrated into the existing monthly registers as well as the DHIS2 platform for data tracking, because we need adequate feedback to have quality of care and quality. It's a quality improvement process, and that's just it.
Yes, thank you so much. Thank you for that response. I'll come to you. Oh, please do give her a round of applause. That was an excellent response. So you have worked, Mrs. Mohammed, you've worked I mean, in the accelerating results for nutrition in Nigeria, accelerating nutrition results in Nigeria projects, for example, that you have led, the adolescent health project you've led as well. You've had a vast experience across resource-poor settings, including in conflict-ridden settings as well. What are your thoughts on how the emotive bundle can be adopted and scaled up in these settings, in primary healthcare centers, in resource-poor settings?
Thank you very much for that question. We talk about advocacy. We make rhetorics out of advocacy, but is the advocacy coordinated in terms of getting to all the levels? Most times, advocacies, policies remain at the national level. Does it get to the state level? Does it even get to the local government level? I'm happy to know that the president has allowed local government to earn their money. Can we advocate to local government to make concerted effort in allocating resources, and not only allocating, because those of you who have worked in the development world know when they say they allocate, but are there releases for this so that the primary health care are well equipped, not in terms of the equipment, but the manpower. Where are the manpower? I go to the facilities, I will see environmental health officers in the labor room. They don't have the basic training for that. Is that what we want to see? Because we don't have the right people to advocate to. Because if we do that, we tell them these are the kind of cadre of persons that are supposed to be in the primary health care and in this particular department within the primary health care. Probably we will get there or will have gotten there. I've worked in Zamfara State and I found they had only 2 personnel in the PHC. Every other person, about 20 of them, are primary school leavers, secondary school leavers, earning salary. So where are we? Are we really serious? Are we serious? Then looking at the tax shifting, tax sharing policy, can we bring that up and make sure that the low-level providers, who are mostly found at the primary health care level, are also taken along? We don't leave it at the big providers, the nurses, the midwives, and doctors. PHCs in northern Nigeria, you have CHOOS in the primary health care. They are the ones doing everything. They call the show. And the CHOs, very few CHOs. Then are we adapting the e-motive so that it's scalable enough and with scale in mind? Are we doing that? Are we considering this? Because the question I wanted to ask Professor Galadenchi is, where did we test this? Is it in urban facilities or rural facilities? Because we need to know how it works. And we need to do some comparison. We have to do a little bit of adaptability in the rural communities. Look at the issue of the drugs she's talking about, 14 different oxytocins. Only 2 are useful. Do we have a primary health care center that can keep the oxytocin potent for the providers to use? Do we have that? Do we need to work with the manufacturing agencies to see if we can have oxytocics that can be accommodated in the primary healthcare centers where there's no light? Can we do that? Then looking at how do we measure it? Because we need to measure to know whether we are moving through the right direction. Do we have the right indicators? Or we are bringing out indicators that cannot be measured or will not be useful? My experience working with primary healthcare workers is that if they don't see the use of the data they are collecting, they will not collect it. And are we making the data collection very easy for them to use and not heaping work on them? Then, of course, are we using the data generated by these same people to take decisions and make some modifications so that they feel relevant? I mean, even in the Maslow's of hierarchy, self-worth actualization is one of it. Being part and parcel of a system and being recognized as some. If I come with a problem, am I being listened to? We need to do that. Then, of course, the private sector. Where is the private sector here? In SFH, we've worked with the private sector, the Pharmacists Association, to bring in the patent medicine vendors. Because there are people that people go to, do we ignore them? We decide to say, okay, maybe we need to bring them in so that they provide some form of primary health care services at the community where they are. In Gombe State, many years ago, I went to a certain community. I had to climb 45 minutes to get to the top of the hill, then another 30 minutes to go down there. There wasn't, maybe now they have, there wasn't a PPMB there. What happens to that woman there? What happens to my sisters there? What happens to my daughters there? So we had to talk with the PPMBs to please, can you visit there and touch your tent on market days so that at least the women can get some MNCH commodities, some clean delivery kits. And we left the community health volunteers there to identify emergencies right from pregnancy. How can she take them down? So all this we need to consider before we talk about the emotive. Is it adaptable at the PHC, and how, and with who, and with what resources? Thank you.
Thank you so much. Thank you. You've touched on so many things. You talked on manpower, on the shifting tax sharing policy, on the availability of drugs. It's a good thing we have Dr. Nonso on the panel who can speak to the point you raised about oxytocics. You talked about data collection and use. And I mean, I'm glad that Prof. Galadanchi is still online. Hopefully she can chime in at some point, speak to your question about what facilities they were tested in, because that's a very valid point. So thank you so much for sharing all of those. Let me come to Dr. Habib. You will speak from the specialist perspective. You are the immediate past president of SOGON, Society of Obstetrics and Society of Gynecology. I keep doing it. Gynecology and Obstetrics of Nigeria. And I wanted you to reflect on past approaches that specialists use in management of PPH, past innovations as you respond to this. And my question is simple: what are the considerations? How is this adaptable in a healthcare setting, specialist or otherwise, from your experience?
Thank you, Kemi. First, let me begin by thanking Lillian and her team for the work they are doing in health, especially maternal health. They've been holding this kind of discussion for a while. And let me tell you, I follow your top 10 new health items on the emails. And I filter. I look at the maternal side mainly. Thank you very much. Now, emotive is really a highly welcome thing. Like Professor Galadanchi said, it's an innovation of putting things together. As obstetricians and gynecologists, for the last maybe 10, 15 years, longer than that, I think, maybe 20 years, the instinct has been active management of third stage of labor. And it consists of all these things except for setting a line and using the drip. In some cases, the drips were also used. When we're using anti-shock garment for management of PPH, drips were used. But oxytocin, massaging the uterus, checking for laceration, these are all part of the active management of third stage of labor. And now what we are doing then was, like you said, we are doing them in turn. You give oxytocin, if no contraction, you massage. You then see whether you check for laceration. You also set up the drip later. After all this while, the woman is still bleeding. You get the theater ready so that you can take her for the operation. But what is happening now with this new approach is to do them at once. Once you see the woman has bled to a certain level, 300 mils, that's an alert line. You now start the bundle all over. Even if you have given all these things before, you now start all over and give them all at once. So it is a teamwork. You need people to assist you so that the actions can be done simultaneously. Now, this is very good. And for as far as obstetricians are concerned, this is not a problem. We can do that. And we have been doing them in turn, but now with the new innovation, I think it will be very easy to adopt. And not only, as we know, most of the obstetricians are in the faculties. So taking this into the curriculum of the undergraduates would be a very simple thing because they are the teachers. And in practice, Sorghum 2 has been adopting primary health centers to offer voluntary services, what we call Obstetricians Volunteer Scheme. And by doing that, we train, we provide service, we train, we also mentor. So this can be carried down. Now, we have several issues. I'm very pleased that the Federal Minister of Health came in right on time, and they've adopted this e-motive. We've even developed a training manual, which will be used to train all healthcare providers at all levels, and I hope this will be done at a scale very soon, so that everybody becomes conversant with the new approach. But the issue that we'll be going to face, initially, these drapes were not available. I'm happy to say that I've seen locally produced drapes. Some of them are not biodegradable, so there may be a challenge on disposal. But the major concern is federal government has a limit where they work, tertiary institutions. The state government are supposed to operate the secondary care facilities, and they have to have extent with the primary health care under one roof, taken over the management of primary health centers. Now, my greatest concern is getting these supplies. They're not very expensive, and they're not difficult to find. But we know how our governments are behaving when it comes to doing things on a repetitive basis. If he's doing one project, one off, the governments can do it. You want a hospital built up, they can do that. But you want a regular supply of oxytocin. You want regular supply of magnesium sulfate. That's a problem. You want a regular supply of the drapes. That may also be a problem. So I think this may be the challenge that we'll be facing. We need to really, the federal minister, the federal government needs to talk to the governors, and now with the new approach for providing direct funding to local government chairmen, we need to talk to them to pay attention to health in particular. And there should be somewhere a catch where they must be forced to supply these items to the delivery rooms. If we don't do that, the e-motive is there, people are trained, but they cannot perform because the supplies are not there. Now, if you recall, Vivian mentioned something from the 2018 DHS. That is only 43% of our mothers delivered under supervision. That is another challenge we are going to face. If we address e-motive in the health facilities, certainly we'll get a significant reduction of maternal mortality of patients who attend the hospital. But now we have out there 60% of our women delivering at home. They are getting support from the TBS. They are getting support from relatives. And I think in the report it said 11% deliver alone. It's more than that, actually. There was a study that we did some years back in Gusau and around in Zamfara State and Sokoto. We found that 40% of women delivered with no one at all. All they want is to hear the cry of the baby, then people will rush into their room. She has delivered. Then the TBA will be called to come and cut the cord. That is a long period of time for her to bleed and die, unfortunately. So this 60% of women who are delivering at home, we must find ways of bringing them out. If we are going to have a significant impact on our maternal mortality, 43% only are getting skilled care. And that is when you can apply your e-motive. Very good, fantastic. 60% reduction in severe PPH. Not only in mortality, but just severe PPH. That is to say, women who would bleed up to 1 liter in front of you. Because if they do, the 40% that may do, you can transfuse them. Now, blood transfusion is another issue that we need to address in this country. It's a major challenge. We have mobile blood banks. It is when you need the blood, then you say, bring your relatives. We bleed them and transfuse the mother. There's no time for that in PPH. PPH can kill within an hour. getting relatives to donate blood to cross-match will take more than 1 hour. And really, PPH is something that you just don't want to see when it occurs in the labor room. Every obstetrician, every provider is afraid of PPH. When you see a woman pouring blood, you get totally scared and disturbed. So this approach of identifying bleeding early is very, very important. And I think will have an impact as far as delivery under supervision is concerned. But my major concern over the years has been, how do we get this 60% of women to come out? Let me tell you, if you go back to those statistics, Vivian, you break them by region, you find in places like Zamfara, Sokoto, only 25% of mothers deliver in hospital. In Bauchi, about 27%. Why I'm telling you this is because I worked in these states under different projects. Nasarawa, similar thing. So you see, out there are many women who have no care at all. They receive antenatal care all right, but they deliver at home. Because the policy amongst the House of Fulani practice of delivery is that if you ask the woman, have you delivered normally? You know the answer? She will tell you, no, I delivered in the hospital. Did you hear that? No, I delivered in a hospital. Hospital delivery is not considered to be a normal delivery. And that is another challenge we have. When women deliver at home and they start rushing to the hospital with complication, they often come too late. And they will still die in the hospital, and you count that as a hospital death. But they come too late. They are coming almost at the point of death. Before you arrange anything, they can die. So there are these challenges out there, but there is also a few challenges in the implementation of the e-motive. It's very good. The way they worked, and I've seen the program in Kano, how they implemented it is so good. And if you train people and they're prompt, you can see very good results. But we have to have the supplies. There must be regular supplies of oxytocin. When you're talking about oxytocin, there are options these days. Misoprostol is equally effective. Carbitasol is also there. It's available in some states. It is a little expensive, but I think PMJF is working hard to get it down to be at a lower price so that it can be affordable. These two drugs are stable under normal temperatures. The oxytocin requires refrigeration. That is the problem with it. And not only because the cold chain is broken and when it is obtained in the markets, in Kano medical, what do you call it, Dangoro now? The Dangoro Kano medicines market or the Onitsha market. Before it gets to Sokoto, it's out of the fridge. So by the time we get there, it has lost maybe about 80 to 90% of its potency. So when you give, it doesn't work. But we are lucky now we have options like misoprostol is also available, freely available, it's cheap, and we have also carbitasol. So really, the e-motive is something that we must adopt and implement immediately. But there must be the political will on the part of the policymakers, the governments. We have to work. Health Watch has to take this advocacy further. I thought this discussion would include some policymakers, not just the Minister of Health, but even the House was the Senate, and also other departments, not just Minister of Health, but Finance and where they do the releases. We just heard from Fatima that allocation is on release. And if you allocate and you don't release, that's no money at all. That's no budget. So I think we should have had more people, even in this room, to listen to this. But we must carry this advocacy to tell them that postpartum hemorrhage is #1 killer of mothers. And we have a solution to that. If we can address it squarely nationally, we'll get a reduction in the total maternal mortality we have in this country. And then we can now be talking like other countries, like India, like other, what do you call this place? Sierra Leone? What do you call it? No, not Sierra Leone. not the Southeast Asia, Ceylon, the former Ceylon, Sri Lanka, they eliminated maternal mortality long time ago. And then India followed recently. India and us were competing in position. We have now taken over as number one producers of maternal deaths in the world. I think it's not an honor. It's not an honor. We need to do something. We know what to do. We have what it takes. We have all the resources to do it. But we need the goodwill. We need the political will. We need the concern of our policymakers and also the governments to come in and address these issues. But I think we have to find a way of getting more women to get out of the houses and deliver in health facilities. That way, we can have an overall reduction in maternal mortality. But of course, e-motive is highly welcome. As Society of Gynecology and Obstetrics of Nigeria, I'm sure we'll adopt it very quickly. We'll train our providers, our own members, and then we'll train other people, and also put it in the undergraduate curriculum. I saw the registrar of National Midwifery Council, he has left. I think they will also do that very quickly. They're very proactive. I'm sure they'll put this e-motive in their curriculum, in the pre-service curriculum in particular, so that people come out ready to serve. So I think, thank you very much.
Thank you so much, Dr. Habib. Thank you for running through some very important points. What you said about supply chain and logistics management, you know, when the Honorable Minister of Health, Prof. Pate, had given his speech during the Safe Motherhood Day in April, he had mentioned that the calibrated drips would now be included in the logistics management information system. But I would not ask Dr. Binyerim yet, since it was in April, how that is going. But I think those considerations are there, and it's good that they are top of mind. And having dialogues like this, your points about having more people in the room, absolutely, they're very on point. Your points about blood banks, thank you so much for sharing those insights. So I'll come now to you, Dr. Nonso. You lead the Smiles for Mothers project, and you are tackling one of the key issues that Dr. Habib had raised, and as well Mrs. Muhammad here, about oxytocics and how applicable they are in our settings, especially in hard to reach and resource-constrained settings. But you've learned a lot from implementing the Smiles for Mothers project. Could you share your thoughts on how some of the lessons from Smiles for Mothers, trying to scale up the use of heat-stable oxytocics, some of the lessons from employing a human-centered design approach can be adopted for the scale-up of the emotive bundle?
Thank you very much, Kemisola. I think before I respond to the question, I'll join my co-panelists in congratulating the Nigerian Health Watch for organizing this timely policy dialogue, and I must say it's excellently executed, so well done to the team. I think before I then go deep into the question, I'll provide some context about what Smiles for Mothers is about. First and foremost, we're a consortium made up of Solina and Chai, initially engaged by MSD for Mothers between 2020 till 2024 to support Kano, Lagos, and Niger to implement the then latest PPH, WHO PPH prevention guidelines. We also did some TXA assessment work. I'm providing this context so that you will then see how it links to the lessons that we learned. For the PPH prevention guideline, a major part of that was the introduction of heat-stable capitocin, which Dr. Habib mentioned, which was already available in Nigeria for years, but was mostly used for high-risk pregnancies, or high-risk deliveries rather, specifically cesarean sections. And what we were brought in to do was to help the introduction of a public access price version of it, which addresses, the comment about the cost of heat-stable capitocin. And, just even reflecting on some of the things that have been said today. That was also an example, a very good example of how strong partnerships, made that happen, because that was possible through partnerships between MSD for Mothers, WHO, and Ferring Pharmaceuticals, who were the producers of Capitocin Ferring, which is the public access price version of heat stable Capitocin. And for us, we used the framework that was built on 3 pillars, for the introduction of Capitocin Ferring at the time. And those pillars were the policy adoption journey, the product journey, and the client journey, which of course we also used to do our human-centered design for the introduction of heat stable Capitocin. On the lessons now specifically, for the policy adoption, I think one of the biggest things we learned was how some of the national policies, and even state-level policies, revising them sometimes is not enough. And I'll use the example of what I would call the procurement policies, like the essential medicine list. Most of us would imagine that revising the essential medicine list would be enough to introduce a new commodity. But the reality is that within states, you have different funding sources for commodities, and pretty much all of them have their own different lists. So if you update the essential medicine list, for example, you would still probably have to work with the state to update the health insurance list and so on. So just being aware of these nuances is something that I think going into emotive, we should all be mindful of. On the product journey, I would say the biggest lesson for us was the importance of sustainable financing, specifically the DRFs in the States, because once you introduce these commodities, you need to already start thinking of how you would continue procuring them and having them available. And I would say that a major part of our success was the fact that our donors at the time, MSD for Mothers, were able to facilitate the seeding of heat stable Capitocin to those 3 states, which they did through their DRFs. And so far, those states have been able to continue procuring commodities. And I think the good news, as Dr. Habib also pointed out, is BMGF is also looking at doing that in a few more states over the next few years. So I think that is something positive to look forward to. On the client journey, I would say the biggest insight for us was the importance of some of the nuances from the clients, from the healthcare workers, which we factored into our program design. Things like our patient literacy materials, and it's something I would say, especially for us implementing partners, it's something we typically forget when we design programs, not understanding some of those nuances, at that level. And it's very important in designing programs to think of those and incorporate them. Thank you.
Thank you so much for sharing those. Indeed. Yes, please put your hands together for him. Thank you for sharing your insights on that. Indeed, strong partnerships, being aware of the policy environment and all of the different nuances that you have to take care of, leveraging existing structures like drug revolving funds, especially now that we have, a more, sorry, I'm going to use this word, powerful local government tier. What are the lessons from implementing these healthcare programs at subnational level that should absolutely be adopted at the local government level? Because, they are responsible actually for primary healthcare, but we know how that is turning out. So I do have a few more minutes, but I wanted to pause to see if anyone has any burning questions. Oh my God, someone's hand is already up. So I will take only 2 questions right now because I still have a few questions for my panelists and I just didn't want you to feel left out. Also, for those of you that are online, apologies I didn't recognize you initially. Thank you for staying online. If you do have a question, please drop it using the Q&A feature or in the comment section, and if we have some time, we will take those questions before we leave. So I would call the first hand I saw.
to ask your question very quickly.
Thank you. Thank you very much. Very quickly, I think everybody should be alarmed with the revelation of Prof. about, out of the about 14 oxytocin drugs, only 2 were found suitable. And my question really is then, who approved or did not approve those drugs and then in the market? And what are we doing about that? For me, it's really concerning. Then quickly also, my next question goes to either Prof. or Dr. Sadauki. In managing PPH, sir, can a healthcare provider or a doctor override a client's culture and beliefs to save a life? It's an ethical issue, absolutely. Can a healthcare provider override? If no, how do we deal with this? Because at the end of the day, it increases the numbers that we are talking about. Thank you, sir.
Okay, I'll take one more before. What if I just randomly point? Okay, so I'll take a woman this time since that was a man. So, Dr. Amina, please, can we get a mic to Dr. Amina?
Thank you very much for this insightful panel. My question goes to Dr. Sadauki because, I'm very interested in the issue of home births because even though, yes, we are talking about emotive, which would really go a long way at the facility level, in your experience, what are the 1 or 2 interventions that you think we should focus on to be able to move clients from home birth or home deliveries to the facilities? What can governments do? What can other implementing partners do? And which communities members should we target for such kind of, should I say, a change of mindset? Because I know it's a really serious issue. Thank you.
Thank you so much. All right, who wants to go first? I particularly like the procurement question. And I'm eyeing Dr. Binyer. Well, please, Dr. Noso, please go first.
Thank you very much, Kamisela. I think I can take a crack at the procurement question. I think it's just as, I think what Dr. Charity that said, the MNCH space is quite complicated, right? So you would imagine, from your comment, you would imagine that quality of uterotonics stops at approval by NAFDAC or whichever regulatory agency. But it's a bit more complex than that because you have to think about the journey of the drug, right, from production to importation, to storage, to use, and so on. And I would give you just one example of how things might have gone wrong. So you could have a commodity produced, brought into the country, goes through the NAFDAC lab, it's approved. But then what happens to it thereafter? Nobody really knows or understands. And we have, systems in place, right? There's something called the post-market surveillance of these commodities, where on a routine basis, the regulatory agency is supposed to be able to go out to the market and check if what they had approved ab initio is still, the current situation in the market. But unfortunately, that doesn't happen enough, right? So just giving that example to respond to say, yes, most or a good number of drugs are approved, but what happens to the drugs thereafter, is probably one of the reasons why the quality of the commodities cannot always be guaranteed. Thank you.
So if I may add to that, also it's been stated earlier about the storage, the mode of storage for oxytocin particularly. It needs to be stored in the refrigerator at a particular temperature. Then how often do we have electricity? 24/7, 24 hours a day. And in how many facilities do we have all this? Do we have solar panels even for storage? So some of these things, it's possible that as at the time it was NAFDAC approved, it was potent, it was efficacious. But by the time of usage, perhaps it's lost its power to do the very job it's supposed to. So it's quite a complex thing. Just wanted to add that because Dr. Sadauki already mentioned that earlier. Thank you.
Thank you so much. Dr. Sadauki?
The first raise a very fundamental issue, of ethical issue. Are you referring to blood transfusion or all the components of the E motive?
Layman's question, forgive me.
Yeah, okay.
But you take the client into the theater and you may have to remove the womb or something.
Okay.
Yeah, so all of that, you know, do you, yeah, that's...
No, with regards to actual medical management, where required, you sign a consent for a particular operation, including alternative operation. When you sign the consent, it says this particular operation, repair of the uterus or total removal of the uterus. You sign that consent. And if you go in and you cannot repair, you take it out. You are covered legally because the consent is signed. But where I may have problems is maybe when you are talking about blood transfusion. If a woman comes and said, I don't want blood transfusion because of my face, so that is why you have problem. She has already told you, so you cannot say you didn't know. If you dare transfuse her, she can sue you for that. So you have to find alternative means of expanding her blood using other means other than blood, human blood. So that is a bit difficult. I think it's a little out of this discussion. If we continue on this, it is something else. But really, generally, 90% of cases, a simple consent is required if you have to go to the theater, either from the patient herself, or from her spouse, or from a mother, or somebody that is close to her that can stand for her, if she is not able to sign the consent. And that is acceptable. Yeah.
And if I may just add to my boss, he's my boss, so of course...
the tables have turned.
Management, taking care of pregnant women is highly individualized, and when we have such difficult cases, in quotes, you counsel to see if the patient, the woman will change her mind. Where she doesn't change, like he said, you use alternative sources, and at times you even have to ask them to sign against medical advice, because you cannot go beyond her consent.
I have one more question to answer.
Yes, you do. I was about to point.
The home delivery that Dr. Amina Pathfinder asked, I know why she asked the question. It's a very difficult situation. What I was going to tell you is pay them, they will come out to deliver in the facilities. Pay all the mothers, give them a salary, they will come out and deliver. But on a serious note, look, I think we need to do more sensitization in the community, especially to the husbands, to the in-laws, the mother-in-law in particular, who has delivered all her 10, 12, 15 babies at home, and she is healthy and up and about. She will use herself as an example in the community. So you need to convince her things have changed. The kind of food she was eating then is not the kind of food we are eating now. So even for that, she will allow them to come out. So we need to be a little innovative in trying to get them out of the house to come and deliver. Believe me, when we had the MDG insurance that allow mothers to deliver freely in a hospital, there was an improvement in mothers coming out. So finances are a problem. I can tell you in 2001, I was the executive secretary to the Hospital Management Board, and the then governor introduced free maternity services in Kano. Total free, everything, including surgical operations and evacuation of incomplete abortions. In Murtala Muhammad Hospital, the largest hospital in Nigeria, I think in terms of maternity, they are delivering 5,000 women every year. But from January 2020 to December 2021, in that hospital, we delivered 11,720 something mothers. Why? 300 naira was removed from their bill because they paid 300 naira to get a delivery pack and deliver in the hospital. So you can see the difference. And Of course, if they had operation, they will have to buy the things in those before the introduction of the free maternity. But once that was introduced and made free, and the supplies were there, we had 11,000 deliveries, from 5,000 to 11,000, consistently for 5 years. The average delivery in Murtala was about 5,000. But believe me, for that year, it shot to 11,000. And in subsequent years, I think we'll reach as far as 15,000. But of course, did the maternal mortality fall in that hospital? No. It rose, actually. More mothers died in the hospital there. But that means these were mothers who were dying at home. They've now come to facility, but we couldn't help them because a lot of the time they came in too late, or there was, the work was overwhelming. You had only 5 doctors taking this delivery. You have so many number of midwives taking this delivery. What the government did at that time, unfortunately, I'm sorry, I have to say this, was they supported the program, but they did not support employment. So a doctor will do 5 cesarean sections in the night. He will tell you that he cannot take the 6th one. He can't. And then that patient has to wait. Also, she has to survive till the following morning when people come to take over and do the cesarean section. Otherwise, if she goes, she goes. There's nothing he could do. It's done 5 cesarean sections. It's knackered. He cannot do anymore. So truly, if we need to move the mothers, we can. We need a bit of incentive, and we must make the services affordable. They cannot be totally free, because totally free means even the transport to bring them from home is free. So it must be affordable, something that they can afford and pay. And an example of this is the Kano State model for free maternity. That later was adopted by Ondo State, and the ABA project was an was an excellent project. They transported mothers, they gave them cell phone so that they can call providers if they have any problem, and every mother has access to a facility. And of course, like was mentioned earlier on, the maternal mortality in that state, drops significantly. But I don't know what is happening now with the new governments. But this is our problem in this country. Consistency and sustainability is a big problem. But it can be done. I think we can improve. We are improving gradually, but the rate is too slow. Like 65% of mothers attend antenatal care on the average in Nigeria. It varies from state to state. Some state is 90%, in some it is like 40%. But if you can encourage these mothers more with a little bit of incentive. No matter what it is, they will come and deliver in the facility. But of course, you have to equip the facility and you have to staff the facilities too. Thank you.
Thank you so much. Yes.
If I may come in here, yes, you incentivize the women. What about the structure built by the federal government, the CHIPS program? What are they doing? How can we build the capacity of these CHIPS to identify dangerous pregnancies or pregnancies that will be fatal for the woman? How can they escort the woman? Because a lot of them, in our experience in Gombe State some years back, we did an MNH project. The women were saying that they feel uncomfortable going to the facility because they don't know anybody. They are afraid to talk to the healthcare workers. But when we assigned at what level community health workers to escort them and incentivize the community health workers, the facility delivery improved, postnatal checkups improved. So there are many ways to do it. I think it's contextual. Each state will do it the way they can afford to. There's the goodwill must be there, and the kind of people you put forward. But if people still think that hospital delivery is an abnormal delivery, then a lot of behavior change needs to be done to make them know that facility delivery is not an abnormal delivery. It's what we call assisted delivery. Thank you.
Okay. If I'll just add briefly, my experience in Uganda, we went and visited a primary health care center. They have what is synonymous with a CHIPS program, and it's somebody in the community that lives with them, you know, that does that, and they've been trained on maternal and newborn health, so they have their limits of counseling and everything, but they do educate other women, so they're able to identify with this is our own, and they've seen how to. She has delivered in hospital, and she's doing very well. And when they have issues, they escort them. We actually saw them in the health facility. This small PHC was very clean, very functional. The human resource was there. It's a compendium of so many factors. But that link with the community was there through the chiefs, you know, somebody they could identify with, and they actually escort them to the facility to deliver, and they are there for them. So they're already familiar, you know, that we need that connection, that nexus. I mean, it needs to be strengthened. It's already happening through MPHCDA, but it's something we can strengthen. And again, key messaging at that level, health education, awareness, still very important. You know, can we have male champions? We need male champions for even the emotive, you know, at that community level. Yes, thank you.
Thank you so much, Dr. Binyaram. Yes, sir. Please, can we get a mic to him? I might have forgotten to mention, but if you could please introduce yourself when you are asking. Behind you, sir. Yeah.
Thank you. Good morning. My name is Professor Dolapo Emmanuel Lufadeju. I'm the country director of Rotary Foundation, Reproductive, Maternal and Child Health in Nigeria. I want to commend Adiza Galadanchi's presentation and also the very wonderful contributions by the panelists, very distinguished members of this panel, and of course to Nigerian Health Watch for bringing this together. Mine is a comment, and the comment is that I think when we talk about maternal and child health, particularly maternal death, we should look at it holistically. The federal government has a policy on maternal perinatal child death surveillance and response, MPCDSR. And under MPCDSR, PPH is a response component of MPCDSR. Together with that MPCDSR, there is a data system that is web-based and established nationwide already in all facilities and in some primary care centers, with personnel that have been trained to input data, give notification of any maternal death that occurs anywhere in the country, and within 24 hours. And also to review this death within 30 days in all facilities and communities. I believe that this PPH motive should be an integral part of MPCDSR, so that this, whatever happens, if there's any death resulting from PPH, it can be captured and it will be recorded, and you will know what is happening. If you are just doing work and you don't have any means of knowing where what is happening, there is no success there. So I take the emotive PPH as a response component of MPCDSR. And I think Nigerian Health Watch should promote the integration of this particular program with MPCDSR. Thank you.
Thank you so much for that contribution, sir. Indeed. Oh, you wanted to respond?
Yeah, let me just add a voice to what Professor Lufadeju has said. We support both technical and financial support from the Rotary International. with the Federal Ministry of Health, we were able to establish for us the NOCA e-platform for maternal death audit, maternal perinatal child death audit. So that is what it's all about, which is also a quality improvement program, so to say. And he's saying that because through here we track all maternal deaths. And of course, if the maternal death is from PPH or whatever cause, it is there. And then follow-up action response is done to ensure, ask questions. Why did this woman die? Why did the baby die? Why did the child die? And then what do we do? Is this a system thing? Is this? And then you're able to correct. And that's, I think, and it's very important. It's one of the high-impact interventions, just like emotive is a high-impact intervention, evidence-based, that we have to carry on, and it's also one of the ones that WHO, over several years, since 2012, have asked all countries to implement going forward. We are going to keep implementing all these interventions because they are all linked to one another. You can't separate one from the other. They're all very vital. Thank you.
Thank you so much. Thank you. Well said. I'm going to take one last question. I'm so sorry. I apologize that I'm not able to take all of the questions, but there is a question from an online participant I wanted to read out. It's from Fatima Mohammed, obviously not Yuma. Given that CHOOS, community health volunteers, and TVAs cannot administer the comprehensive PPH bundle, and we have a large number of women delivering at home, have we considered community-level use of calibrated drips for early detection and prompt referral? Who wants to take a stab at that? And Prof. Galadanchi, if you're online. Prof. Galadanchi? Oh, you are online. Do you want to take this one? We don't have your audio yet. move on to the next panel real quickly. Thank you so much. Please put your hands together for my esteemed panelists. They have been amazing. And thank you so much once again, Prof. Galadanchi, for joining. Vivian, if you could please come up here, that would be great.
I think that was a very insightful session. We would all agree. And that's why it almost seemed like it wouldn't end. So we'd really have to rush into the second session. While I call on my colleague, Onyekachi Ewe, Senior Program and Advocacy Manager at Nigeria Health Watch, to come and take on the next session. I would like to encourage everyone to keep up the buzz on social media. In fact, tweet as much as possible using the hashtag. If you follow Nigeria Health Watch, you'll see the hashtag giving birth in Nigeria. So if we could, retweet, repost, and join the conversation, let's create a buzz. Thank you so much.
Thank you very much, Emeka. And thank you to Kemi and the great panelists that just discussed the first panel session. Very engaging and thought-provoking session. Quickly, we move into the second panel session. Digitization and data. Want to delve into the importance of digital health solutions. And it's impressive to note that the federal government of Nigeria is prioritizing digitization and data for decision-making in this administration. And we have seen postpartum hemorrhage leading cause of maternal mortality. This was purely data and how this is used in improving and enhancing maternal health outcomes. So quickly, please join me to invite to the podium the panelists for this next session. First, in no particular order, I have Chiagozie Abiakam. She is Associate Manager, MDOC. Please, a warm applause as she makes her way to the stage. You're welcome. Arit Edem, she's the Senior Associate Help Mom. You're welcome, Arit. I also have on this panel Daniel Momo. Daniel Momo is the Customer Success Lead, Nivi Incorporated. You're welcome, Daniel. And I have Njide Ndeli. She's a friend to the house and a very familiar voice and face you'll see. She's the Country Director of Farm Access Foundation. You're welcome, Ma. Digital health solutions. So we've talked extensively about postpartum hemorrhage and how Emotive is used to address postpartum hemorrhage. So now we want to delve into how MDOC has used digital health solutions in addressing even other key drivers of maternal mortality. Of course, there are ample examples, so just share with us in a couple of moments how MDOC is using digital health solutions to address key drivers of maternal mortality. Thank you.
Thank you so much, Onyekachi, and thank you so much, Nigerian Health Watch. I just have to say, the energy in the room, the passion, the knowledge, the evidence has been amazing. This has been such an interactive session. starting with what MDOC is doing to address the risk factors of maternal morbidity and mortality, right? We are taking on this step using technology, right? And we started off, with the RICOM project, reducing indirect causes of maternal mortality and morbidity, funded by MSD, and we've continued this process through Digital Moms project as well as Project Aisha. So we are addressing indirect causes, specifically focusing on NCDs, preeclampsia and eclampsia, right? We're using some of our tech solutions, Complete Health app. This is an AI-enabled digital health app, coach-led app that women, are onboarded to. They are, empowered to take complete charge of their health, right? So they are, their digital literacy is built, their health literacy is built, they are provided with anticipatory guide throughout their pregnancy journey. So they understand what to expect at every stage in their pregnancy, what the danger signs are, and how to take, full action for it. But that's not just all, right? It's wanting to build their capacity, it's wanting to build their knowledge. Another thing is to ensure that they are receiving good quality care, right? So we're empowering their voices, giving their voices, helping them make decisions into quality improvement at the facility. So what we've done here is use our platform called Navi Health to collect feedback on quality of care. That feedback is then integrated back into the system. The healthcare system, stakeholders, facilities, and is used to improve quality of care at the facility, ensuring that quality improvement endeavors are targeted, right? Meeting women's needs and their preferences. But in addition to that, we understand that it's important to build capacity of healthcare workers as well. So what we're doing through some of our programs is to build the capacity of healthcare workers, ensuring that they are well-equipped clinically, digitally, that's AI, as well as with quality improvement methodologies, so that they are well-equipped to provide high-quality maternal health care when the women come in. Thank you.
Thank you. It's important to note that we are using these digital health solutions because there are quite a number of maternal health innovations. We heard that from the BMGF, Dr. Charity, the MNCH lead for Maternal Health Innovations, about the various maternal health innovations that are available and how these are being deployed in our various fields to improve maternal health outcomes. And we just want to delve further and find out how, because digital health solutions has a tremendous potential to enhance maternal health outcomes. So I'll come to you, Ari, now. We can't have healthy babies without healthy mothers, and that's why we always refer to this component, MNCH, as maternal, newborn, and child health. So the Help Mom vaccination tracker, how is this assisting women and the communities you serve to improve child outcomes, child health outcomes? How is this impacting the communities you serve? How are you tracking data as well? Because we're also talking about using data to inform decisions. So,
okay. So some of the communities we work in currently are Oyo, Osun, Kanu, Katsina, and Jigawa. So what we've seen in these communities is that most mothers, despite the fact that they know their child's immunization dates, they don't go ahead to take their children for immunization. This is due to little as forgetting the dates. So what our vaccination tracker app does is to send reminder messages a week before the vaccination date and a day before to ensure that these mothers take their children for immunizations. However, we found out that despite the fact that we send out these reminders, some of these mothers still do not take their children for immunization. This is due to various barriers such as financial constraints, like high cost of transportation. There's also the fact of the proximity from their communities to the health centers. So what we did was develop an AI-driven vaccine intervention optimizer called Advisor. So what Advisor does is it recommends various interventions to mothers based on the information that's being imputed into the vaccination tracker app. So the recommendations can range from bus pickup services, where these mothers in the communities are being picked up from a central location and taken to the primary healthcare centers. There's also the immunization at your doorstep, where we see that if there's a lot of zero-dose children in this community, we partner with the immunization state officers to take this immunization to the doorstep of these mothers. There's also the travel vouchers. For some people, they want to take their children for vaccination, however, they don't have the money to do so. Then there's also as little as providing enough information about the immunization their child is due for and its importance. That has also seen to reduce the number of vaccination dropout rates at primary healthcare facilities, as well as reduce the zero-dose children at the communities. In terms of measuring this matrix and impact, what Advisor does is at the end of the month, it measures how many children were supposed to take their children, how many mothers were supposed to take their children for immunization versus the number of mothers who actually did. It also measures the most cost-effective intervention out of all the interventions. It also measures the intervention that was most efficient in ensuring that these mothers took their children for immunization. So these are some of the ways we measure our impact.
Great, thank you, the advisor. And it's good to note that there's a component of incentivizing women and encouraging them to move from just using the mobile digital apps to actually receive continuum of care at the health facilities. You know, while the previous session was going on, I was having a side talk with a colleague on how incentivizing women to access care can be sustainable. But I think that would also lead us to another conversation around healthcare financing. So I'll move on to Daniel from Ask Navy. And yes, digital health solutions, revolutionizing healthcare delivery. How is Ask Navy integrating these technological advancements into maternal health care service provision? Tell us a little bit about the work you have done and how you're integrating this advancement into maternal health care delivery.
All right, thank you very much. Nice to be here. I think it's also good to start by saying that comparing the traditional mode of health uptake with, digital innovation. So with the traditional, way of health uptake, you have health service uptake, you have the patient going to the doctors, and getting prescriptions and hopefully following this prescription religiously. You have this vertical, hierarchical kind of interaction between the patient and the doctors. In digital health, we are changing that. And what we are doing is we are focusing more on the patient. So the focus is more on the patient. The healthcare providers are still very important, obviously. But here we are giving the patient more options, okay? We are empowering them, deepening their knowledge about, various health topics, and making the interactions between the healthcare providers more dynamic and more interactive. Okay, so even before the patient goes to the provider, they are already informed. They are going as a well-informed patient, and they're able to engage the healthcare providers effectively. So at NIVI, we are doing that across various health topics, like from reproductive health, various primary healthcare topics, and of course maternal healthcare topics on our chatbot service called Ask NIVI on WhatsApp. So how Ask NIVI works basically is to provide patients with, is to equip patients with information and equip them with information, and you have a well-informed patient going to the being recommended to the different healthcare providers for care. And for maternal health, we've been able to successfully do this by supporting women. We had this intervention deployed in the SMGL 2.0 project in Kaduna for Pathfinder, where we supported women in northern, central, and southern Kaduna. And how this basically works is that we start supporting the women with health content from the 10th week of their pregnancy all through when they give birth, and also 15 weeks postpartum. So we support them with healthcare content that relate to their status as they progress in the ANC journey. And we also ensure that we keep track of this interaction through feedbacks. So the women visit, they are recommended to complete at least 8 ANC visits at these healthcare centers. And during those periods, they provide us with feedbacks. So we're able to monitor the interaction between them and the healthcare providers, basically. Thank you.
Okay. Thank you, Daniel. So, Saving Mothers, Giving Life, yes, funded by MSD for Mothers, and how you have used digital health solutions to support health information, health communication, providing information to these women through their pregnancy journey, and also receiving feedback, which is really key in terms of using information from these women to improve maternal health care. Thank you very much for that insight. So I'll move to Mrs. Injide. Yes, Farm Access Foundation piloted Mom Care, which also had this digital health solution component to it for about 2 years. And we'd just like to know, and I'm sure the audience would also want to know, what were the problems that you were looking to solve? What were the challenges? We're talking about scaling, moving from pilot to scale. So how has this fared so far?
Thank you so much for having me. But first of all, I must say I feel so old on this stage. So next time, let's invite the younger ones to speak. Yes, so we piloted Mom Care in Lagos State for over 2 years. Mom Care is actually a value-based program, which, layered on top of digital, kind of to track the pregnant women from their journey. And the whole idea was, because we as Farm Access, we've been, kind of developing innovations in the healthcare system as a whole, generally. But also we try to identify priority areas. We had all the statistics this morning. Over 1,000 deaths in terms of the maternal mortality compared to the SDGs. So we felt that we needed to develop some kind of innovation around the digital interventions, especially mobile. Mom Care was funded by MSD for Mothers. The whole idea is how can we intervene at the two extremes, the extremes being the patients themselves, the pregnant women, and the second being the providers themselves. The issues around maternal mortality, women having difficulty reaching care, having difficulty, even just the transportation, knowing where to go, even when they get there, do the providers have the qualifications and the skills to provide the care? So we started in Lagos. Basically what we did was we selected four providers. 3 were public and 1 private. We enrolled over 3,000 women and we followed their journey. The whole idea is how do you identify them when they're pregnant? How do you ensure that you engage them, you monitor them, and then they provide feedback? At the same time, on the provider side, how do you build their capacity, train them so that they're able to provide the care that is needed? And it was very interesting. We got a lot of insights to the mother's journey. We used to give, messages trigger so that they know when to go for the ANC and so on and so forth. And the information that we collected, we're able to feed back into the system to know exactly when we need to reach out to them, when we need to intervene is a high risk, and so on and so forth. So when it comes to, and again, I have to say that the reason why we tried it in Lagos, it was in partnership with LASHMA, which is the Lagos State Health Insurance Agency, because we didn't want a pilotitis where you start a program and when the funding ends, it collapses. So from the get-go, we thought about sustainability. How do we integrate it into an existing health insurance program so that when we determine what the issues are and we solve them, then it's able to run by itself? But very quickly, talking about why, what issues we identify. One is, first of all, the individuals. We started at a level where we wanted the patients to pay for themselves, the pregnancy bundles. And we realized that we were targeting, even though the information was useful, we were targeting those who could really afford to buy insurance or could afford the care themselves. So one is that there is a lower segment of the population that needs support. And those were left out from our pilot. Two is, the providers themselves. There's so many programs. If you go to any provider that is doing well, he will tell you that the number of donors or developmental partners, you've come again with another program, even though it's helping, but it's also creating a lot of burden for the providers. So, the initial skepticism and so on, that was another problem. The third is the issue around data collection. You want to collect data to analyze, you find that a good percentage of the data is in manual form. So you can't really analyze. It takes you more time to code the data you've collected into the system before you can even analyze. So, you're talking about individual problems, structural problems, and, kind of infrastructural problems. So then again, the issue of interoperability. So we had, even though we were just dealing with 4 providers, you have to be able to aggregate the data. So that was also very difficult. So you find that as we develop innovations, especially for the innovators in the room, there are 3 S's that we try to focus on. Make it simple, make it scalable, and then make it sustainable. With these 3, and of course, but another reason why there's not a lot of scaling is because we don't involve the regulators. Even in this case, we involve LASHMA, which is the government counterpart. But still, they have to be involved in the design. Otherwise, you're bringing them in at the end, and they feel it's your program, not mine, and then scaling becomes also an issue. I could go on and on, but I think I'll leave it there for now. I think it's very important that we think holistically when we're designing. Always think about integrating it into an existing program, not a standalone. I often say, how do we begin to horizontalize all these vertical programs? Because in and of themselves, they operate in silos and it's not sustainable. So I'll leave it at that for now.
Thank you. Yes, I was going to say it's a good place to clap. Thank you. It's very interesting to note that, yes, these digital health solutions require leadership from government, both at the national and subnational, and also involvement, collaborations from the private sector, and also tailored solutions to specific problems, where we now talk about human-centered design. So thank you very much for providing these insights on the challenges that prevented scale or has prevented scale, competing demands, creating these burdens for providers, data problems, and also the need to target the lower segment of population that needs support. And my takeaway would be in bringing in these innovations, make it simple, make it scalable, and make it sustainable. Thank you very much, Ms. Sinjide. And that's why we really needed you on this panel, because we like the balanced view. So I would like to mention that, no, we don't feel too young in your, in your presence, and you shouldn't feel too old in our midst. Thank you very much. Okay, so I would want to take a question from the audience, so you do not feel left out. Do we have any question? Yes, the first hand. And the second hand, I see a familiar face also in the audience. So let's take the two questions, and I'll come back with an additional question, and we'll wrap this segment.
Okay. Thank you very much to our wonderful panelists for taking us through the wonderful session. Yeah, so my question goes to one of the panelists that talked about using AI to mobilize pregnant women. And then I would like to chip in data, talking about our literacy rates of women, particularly in northern Nigeria, because we carried out a project in one of the northern states to mobilize women to health facility to take up XP, right, to prevent malaria and pregnancy, using text message. And in that particular state, literacy level was below 13%. And then there was an issue, or a cultural issue, of what's it called? Not issue around marriage, trust issue in marriage, that the husbands denied women phones. So the women don't have access to phones. So when you send these text messages, the husbands receive them. And they don't pass this message to the wives. So we found out that there were a lot of SPs in the facilities, women were not coming to receive them. That is we're trying to use technology to mobilize women. So my question is, how have you factored the illiteracy level? Especially I'm from northern part of Nigeria, and I will tell you that it's a fact, right? How have you managed that? We have a lot of internet subscribers, over 200 million in Nigeria. Voice subscribers, that's a good figure. Broadband coverage is 46%, over 46%, which is a good avenue to leverage on, to pass on this message. But these issues arise of illiteracy and the issue of husbands trusting their wives to hold phone in some, so in some contexts, right? How about leveraging on existing structures, just like the last madam mentioned? The chiefs had been there, WDCs have been there, World Development Committees, Village Development Committees. How about giving them this digital device? They have these registers of these pregnant women. When it's time, they go to this. They are community members. They know these women. They know these people. How about empowering this? Let's start from that level. Empowering these existing structures before, as we progress, we carry the women along. Thank you.
Okay. We'll take the second question, and then the panelists would respond. I'm glad you asked the question and also gave recommendations, so thank you.
Okay, thank you very much. So I particularly liked the innovation, the AI-generated innovation that allows women to be picked up at designated points for immunization, because that has implications for turning women to advocates. So I want to ask whether there are other deliberate efforts to move these women from just being beneficiaries to advocates, and then if there is also any active collaboration with the government. For example, I know at a time the Health Promotion Division of the Federal Ministry of Health was also mooting the idea of having like a media center that can also be used as referral points for people to call in and they get referred for services. Thank you.
Okay, thank you, Olumide. I'm sure the rest of the audience will also want to know you, so please just introduce yourself.
Okay, my name is Olumide Adefioye from the Momentum Safe Surgery Project. Thank you.
And the person for the first question as well. Thank you.
Okay. I'm Jan Charles from Cognito.
Thank you. Okay, so the questions for Chiagozie, MDoc, and Arit Help Mom. So Chiagozie, you go first.
Thank you very much. I would answer the first question, right? And I'll use 2 points. In order to implement a digital innovation and to scale it, some of the panelists have already highlighted collaboration is very important, right? Understanding the context where you're implementing is also very important. So you talked about digital literacy. You talked about situations where you're sending messages and it's the women's husbands that are receiving it as opposed to the women receiving it, so they don't actually get the message because in the household, it's just one smartphone, right, or one device that's available. So understanding the context is so important in developing solutions. You can't do it alone. And the focus is not just on the women. It's also on the influencers. It's on the community. It's on the men as well, right? It's also building their own health literacy. It's also building their understanding. It's also helping them understand the impact of these danger sites. It's also helping them understand how this affects the woman's journey, right? At MDoc, we're very intentional around digital literacy building because our interventions are actually focused at low-income communities. So what we do is at onboarding, at different stages in the woman's journey, we build the digital literacy of the women that we serve. We start off with even taking surveys to understand what their baseline assessment is at the start of the program, and then we do follow-up surveys. So at onboarding, at generating demand, there's a lot around being able to use your smartphone for health. A lot of people that own smartphones, you see that they're on WhatsApp, they're on Facebook. If you're able to use WhatsApp, if you're able to use Facebook, you're able to use your phone to make informed decisions about your health. So that hand-holding initially is done, and then creating value in the interventions that you're providing also helps, in the long run. Thank you.
Thank you.
Okay, so I'll take your first question on the other deliberate efforts we're making aside the deployment of this vaccination tracker app. So like you rightly said, what we do, latching on what Chair Gozie said as well, there's some cases where the mothers are not the owners of the smartphones. So we have state officers in this primary health care primary health care centers who we've enabled with devices to basically collect data for those who don't even have smartphones. We ask, you have a mobile phone, if it's your husband's number, if it's your mother-in-law's number, someone who essentially stays in the same house as yourself. So we collect their phone numbers. We use the community health extension workers who already are domiciled in these communities to reach out to them, right? So it's not just a push message. We also supplement with other efforts. In terms of making them advocates, we also do that because in some communities that we've worked in, we've seen that the major problem with regards vaccine uptake is around the misconceptions and the myths about some certain vaccines. So what we do is these mothers who have taken their children for vaccines and they see that these children are healthy, nothing is wrong with them, they tell their friends, I took my child for this immunization, it's good, nothing happened. In fact, they can come and pick you up from your house and take you to the primary health care center. And this encourages them and builds their trust, right, to take their children for vaccination. In terms of collaboration with the government, we cannot obviously deploy any of our digital solutions without collaborating with the state government, either at the primary health care board level or at the State Ministry of Health. So we collaborate with these two agencies to ensure that our digital health solutions are deployed in a manner that is acceptable. We also make sure that these digital health solutions are bespoke made to fit the cultural beliefs of each of these communities. So they're tailored specifically for that community. I believe I've answered your questions.
All right, I just want to make some addition. Okay, yeah, so thank you very much for that brilliant contribution. I think we just need to face it here. We are talking about digital health here. And there are some certain barriers that mitigate service uptake when you are using, health-enabled digital innovations. And that has to do with a lot of things. You have the educational level, the literacy level rather, you have internet penetration, you have social and economic infrastructure, and many other factors that sort of mitigate the area of using technology to drive health innovation. And so when you are making designs like this, like you earlier mentioned, it has to be holistic. So how we approach this, because a baseline assessment test was actually carried out before while we were deploying NIVI to SMGL, and all these factors, were, came up, and we saw them, and it, became something that we had to deal with. And how we approached that at NIVI was, first of all, all the content on Ask NIVI is in English. We now realized that we needed to translate everything to the Hausa language to make the content more relatable and accessible to the women. Secondly, the factor of, smartphone, just one smartphone in the household, we realized that we needed to carry the partners along where possible, and also the health workers in the community. So when the women visit the healthcare facility, the TBAs, in case of the TBAs, or the nurse attending, helps in this case and say, okay, so what we actually did was that we also had healthcare facility onboarding engagement. So we had the digital onboarding model where they discovered Ask NIVI on social media and all that for those that are literate. And then for those that are not so literate, the healthcare facility, the healthcare providers helped in this, in engaging them and explaining some of these things to them. So the challenges are there, and thank God we are talking about policy making here. I think maybe this is a good time for us to make the appeal, especially for those that can affect, that are influential in this case, to begin to look at factors that affect digital healthcare in implementation. So we are talking about, there was a time in Kaduna where we had these Boko Haram issues, and the internet had to be shut down in some parts of the state in order to manage the situation because of the security threats. That also affects the implementation of the program for a while. So what I'm trying to say is that it's a holistic program, it's a holistic, we must have a holistic approach to healthcare innovation, especially when you're driving it through digital means. And we are here as players to do our part, and we're also appealing for government and relevant authorities to look into these various aspects for improvement. Thank you very much.
Thank you very much, Mr. Daniel. Yes, and that is why we call this a policy dialogue, because the whole aim is for us to, for the policymakers to create that enabling environment for digital health solutions to thrive and actually fulfill the promise of creating of its tremendous impact that it can bring in enhancing maternal health outcomes. On behalf of one of our panelists, I would apologize. She had to quickly leave because she had a flight to catch at the moment. So that was why we excused her, and I beg that we also excuse our panelists who had to leave in the middle of the session because our time was far stretched. Just as part of wrapping up our thoughts, our time is really far stretched and we wouldn't want to keep our audience further than this. Yes, I know you have mentioned suggestions in scaling in maternal health innovations and innovations at large. What other recommendations do you have for other maternal health innovations, other innovations that are enabling maternal health outcomes, improving and enhancing maternal health outcomes, or addressing key drivers of maternal health, access to financing. What are your thoughts as we wrap up?
Okay, so I want to quickly address that with a follow-on question from a comment somebody made about disseminating the phone in the community. And I'll address that using an example that is currently ongoing in the TB space. For those who don't know, there is a mobile application for TB screening, which PharmAccess developed with funding from the Global Fund. This is a typical example. In fact, we've just written and released a blog around it because it's a typical example of taking an innovation to scale. Now, what it is we took the algorithm from TB, or not algorithm, clinical protocol for TB screening, and we digitized it into a phone, both feature phone and smartphone, and we disseminated it into the community. So it's a series of questions. When you're asked a question, depending on your answer, the app will tell you whether you're TB presumptive or not, and then will triage you to where you can get tested. Now, believe it or not, this was developed together with the support of IHVN, the Institute of Human Virology, but we involved the National TB Program from the get-go. This was in the year 2020. Now, when this was launched, I think we were still very much lower in terms of TB detection. And as of today, PharmAccess has actually exited the project. The tool has been scaled to all 36 states in the country. I was at the launch of the TB strategy, including private sector. I think it was last Friday in Lagos with the minister, Dr. Pate. And we've increased our TB detection to almost 26%. From very low, I think it was 10% or so in 2000. So basically, we screened over 3 million people in less than 3 years. So the point I'm making is that we can use the tools. Digital is an enabler. It is not going to do the work. So it will help you triage. So that's one example. The second example is access to finance, the PPP at the primary healthcare level. You find out quite a number of the cases that we're getting actually in the rural area because they cannot reach the facility. And even if they reach the facility is not manned. We talk about 30,000 PHCs, of which less than 20% are functional. We are yet to validate those numbers. But another scheme that we run in Delta State, we took 15 PHCs, and in collaboration with private sector, we got them operational. They were totally abandoned, which means that encounter was 0. Then we started, we put in all the infrastructure, all the processes, of course, private sector with its efficiency, over 200,000 footfalls. Now, I can tell you that the people that were using those facilities were pregnant women. In fact, in one of the clinics, we got an SOS. These women were delivering like 100 babies, 200 babies a month in one clinic. And I can tell you that as of today, there has been 0 maternal mortality. You can go and check that. We've done an impact evaluation. And we've compared it also to the state-run PHCs. And the difference is huge. Why? Okay, the women are pregnant, they go to the market, they want to wait till the end of the market day so they can go to the hospital. When they get there, there's no light. What happens? They go home. So private sector was able to turn that around. So what I'm saying is that in conjunction with the digital devices and the mobile technology, we can actually do we don't have to reinvent the wheel like we heard in the beginning. How can we upgrade what already exists? How can we ensure that our facilities are manned, they have drugs, they have services within them, so when the women get there, they can actually get treated. So these are just 2 examples I want to use. The private sector has a huge role to play. Developmental partners, when we're developing innovations, we should try to integrate it into existing programs, not a standalone program, something that will sustain itself, and that there's room where we can then leverage on digital or mobile technology to help accelerate and improve the care. Thanks.
Thank you very much. Please, a warm applause for this great insight. Yes, digital health is an enabler. Yes, we have to note that at the end of the day, digital health solutions won't do the work. We need partnerships. We need an enabling environment. We need policies, regulations enforced. And private sector, the role of private sector cannot be overemphasized. And we want to begin to see this play out. After, beyond the conversations, we want to see the real time and the day-to-day involvement of the private sector. At this juncture, I would request the panelists to please rise. Thank you so much for your participation and engagement so that we can take a group photograph. Kemi, please, if you're free at the moment, can you join us? Thank you. Vivian, please. Thank you. Thank you very much. Please, a warm applause for our esteemed panelists as they make their way back to their seats. Thank you. And I forgot to tell you my name from the beginning. Work with Nigeria Health Watch. Thank you very much.
Thank you so much, Oyedikachi. I could pronounce your surname and your name without murdering it. And to our distinguished guests that have stayed here up until this time, thank you so much once again. It's been a very insightful, and also to the participants online. We've taken as much questions as we could take. We know that we've overrun, so we'll try to move very quickly into the next session. And I'll call on my colleague, not the session, please. I'll call on my colleague. People are scared. We are wrapping up, actually. And of course, in line with your expectations, we want to get the presentation of the communique. Chris Bassi will take us on the communique. Thank you very much. And he's also our events and programs manager, who has led the efforts in putting this together. We've got very good commendations. Of this policy dialogue. Thank you, Chris.
Thank you. Thank you very much, Emeka. Again, I want to say thank you all to our participants, both virtual and physical, who have dedicated, sacrificed your time to stay up until now. I hope this has been a beneficial discussion to you all. I know it has been for me. As Emeka had mentioned earlier on, in health, maternal health, let's say, show me your maternal health indices, and I'll tell you, I'll tell your country who you are, essentially. And this particular discussion today has centered around primarily postpartum hemorrhage, which is a leading cause of maternal deaths globally and nationally. And so the panel discussions had centered around scaling up of the emotive approach, which has shown to be quite effective in addressing this. We also got the charges from our speakers, talking about walking the talk. We no longer need to focus on just piloting these initiatives, but now scale up, large scale up of these initiatives from subnational to national. So yes, some of the areas we have talked about here today include the gaps in data, gaps in capacity, also talking about subnational level engagement, especially now given the autonomy that state level actors have in terms of addressing maternal health care issues. And so we've tried to synthesize most of the recommendations that we have heard here today. obviously we haven't been able to do a very comprehensive job. That will take a whole day to do that, but I will just walk us through some of these recommendations, and hopefully this will further contribute to the motivation, inspiration to do more, essentially, in terms of contributing towards reducing maternal health deaths, essentially. So yes, we talked about innovations, how innovations are not always about implementing new initiatives, and innovations can also be learning from interventions that have shown success and investing in the scale-up, which was essentially what our first and second panel discussions talked about. We also talked about reorientating the Nigerian healthcare system towards a more comprehensive primary healthcare approach. We also discussed about improving the healthcare facilities and building healthcare workers' capacity in healthcare centers alongside other innovations. We discussed accelerating efforts to scale up the quality and availability of health data to demonstrate progress. If all these things we do, there is no way to report them, there is no way to refer to them, then it's almost means that all our efforts are redundant or rendered moot. And so there is a need for having data that demonstrates the work and efforts that we are all doing or contributing towards reducing maternal mortality in Nigeria. We discussed engaging stakeholders both at national levels, subnational levels, to identify unique challenges and develop innovative solutions tailored towards this specific context. Maternal death, and this was very key for me, maternal death is not a woman issue. It is a family issue, it is a community issue, and it is a global issue, and so there is a need for consolidated efforts towards addressing maternal mortality, both nationally and globally. So there's a need for all departments, stakeholders, civil service societies, non-state actors to support the government in accelerating progress towards ending maternal mortality in Nigeria. Obviously, the government, we can't do this alone, so there's a need for partnerships, there's a need for collaboration, for all of this. And so we also want to commend the efforts by our government, the federal government, through the Nigerian healthcare sector Renewal Investment Initiative, and its commitment towards ensuring that no woman dies as a result of pregnancy and childbirth related diseases. So finally, would like to say accelerate, accelerate, accelerate. There is no time, and with less than 5 years to go with achieving our SDG targets, we all have a role to play to ensure that no woman dies, while giving birth. So again, I want to say thank you all for attending. This has been very, very, very effective and insightful. Thank you all.
Thank you so much, Chris. And just as we wrap up, we're going to call on Dr. Kemisola to give the closing remarks. I hardly ever call her doctor. Nobody calls her doctor in the office. So that's why I was struggling with her name earlier. Well, as you know, Nigeria Health Watch is a health communication and advocacy organization. So what it means is that what we've discussed here beyond the communique, we tend to translate it into our various communication outputs, content, editorial. So look out for most of those outputs on our social media platform and on our website. And thank you so much for following our channels and the engagement. Dr. Kemisola, you're very much welcome to give the closing remarks. Thank you.
Thank you very much, Emeka. I think you already did that. So I'll just end by saying, again, thank you. We can't thank you enough. There will be a QR code displayed on the screen. We hope you give us your feedback, leave us some thoughts on how you think this discussion went and what you would be doing with it going forward. We will be reaching out to you as well somewhere along the line. We'd like to know how the innovations have affected or impacted your work, how it's impacting how you, say, formulate policies, for example. So thank you for being here. Lunch is served. Please do not leave without having lunch. so that the money does not waste. Okay, so please have lunch and yes, continue to engage and follow us on all of our platforms. Thank you so much and have a great rest of your day. And leave us feedback, please.
Thank you. So lunch, yes, for everyone. Group picture, please, before lunch. Yeah, for everything. I think can the camera, any photographer guide us? I think this should be the best place by default. Sam, if you could guide us for a group picture. Okay, he has pointed us to the front. It will just take 2 minutes, please, a group picture. Okay, everybody get up. Director said everybody should get up. Yeah. Please, everybody should get up, please. We've taken as much time. Some people up. Do we bring chairs in front of? I think we. Okay, stand here. Yeah? All right. Yeah, everybody.
Okay, so some people will have to go on top.
Okay, so no chair at all, right? Okay. Okay, so 3 steps, eh? 3 steps.